Good afternoon and welcome to the 99th meeting of the Advisory Council. If I'd only known, I would have actually made my retirement a little bit later so I could have done the 100th meeting. I did not know that. So. Well, in January. In January, yes. The 100th, because this is the 99th meeting of the Advisory Council. I mean, I'll be excited to do the 99th. I mean, that's kind of cool. So we have our normal schedule. There will be one break in the afternoon. Closed session opens tomorrow at 9 a.m. As far as I know, the only missing council member is Dr. Jeffrey Kelly. And I would like to welcome the new council members, even though Peter Lewin was a council member last time. This is his first opportunity to attend. And Dr. M from Duke is here as well. So she is in process on being boarded, so she's not an official council member yet. So, but we're pleased to have you both here. Now Dr. Nard Gavini will be telling us some rules and regulations.
Good afternoon. I have a couple of reminders. Firstly, we are pleased to report that this meeting is broadcast live and it will be archived at NINR YouTube channel. So please make sure you use microphone when you are speaking. Second, we are asked to announce that as a special government employee, council members may not engage in lobbying activities. So it is a conflict of interest. Complete conflict of interest and confidentiality statement is sent to you as a PDF file. And I will be giving specific instructions about conflict of interest at the beginning of the session tomorrow morning. And finally, as you already know, the NIH campus is smoke-free. Thank you.
Thank you very much. Now we'll consider the minutes from our last meeting. They were included in the Day 1 open session PDF for those of you on council, and they're available in electronic council book. I'd like to ask for a motion to approve those.
Question, please. I know. It may not matter, but I don't believe that all the members of the public who were present in May are listed in the minutes. Is that a problem?
You may need to speak into the microphone.
We take the sign-in sheet, and all the names that are listed there are what we include in the minutes. Unfortunately, if they did not sign in, which I'm not sure how that happened, but if you are aware of someone, we can talk about it and I can see if it can be amended. But it's a sign-in sheet that we use.
We'll go ahead and vote on these, and we can add that later if there's some names that you would like to add.
Okay. Move approval.
Any discussion? Any opposed? Motion carries. So the dates for our future council meetings in 2020 and 21, y'all can get out your calendars. In 2020 is January 14th and 15th, May 19th and 20th, and September 15th and 16th. We are primarily back in Building 31 again, so we'll have, most of those will be over there. Then 2021, it's January 26th, 27th, May 18th through 19th, and September 14th and 15th. And again in Building 31. Please let NINR know if you have any known conflicts with these upcoming council dates. We really work very hard to make sure it doesn't conflict with any ongoing meetings or holidays and things like that. So please do let us know if we missed anything. Okay. I want to go ahead and introduce our first speaker, Dr. Michael Gottesman. Dr. Gottesman is a real friend to me and to NINR. He is the Deputy Director for our intramural program here at NIH. And as most of you know, about 10% of NIH's funds go to support the intramural program here at NIH. And you will be hearing later from our NINR intramural program and learn more about that. So it's Dr. Gottesman, his work has primarily been done in the area of cancer research, and he is particularly interested in multi-drug resistance in human cancer cells. In his role, he advises Dr. Collins on all things that have to do with intramural. So at this point in time, he's going to be giving us an overview of NIH as well as his insights into the NINR intramural program. Thank you very much, Michael, for coming.
And thank you very much for this invitation. I have spoken to the NINR Council in the past, so it's a pleasure to come back. And this is an opportunity for me to tell you a little bit about the intramural program and about how the Nursing Institute's intramural program plays a really important role in the intramural program as a whole. So as you've heard, my name is Michael Gottesman. I'm the Deputy Director for Intramural Research. As such, I am the Director of the Office of Intramural Research, which has oversight responsibility for all the activities that occur in the federal laboratories. And that includes oversight of projects and policies, oversight of intramural training activities, compliance with rules and regulations, and I was impressed how few rules and regulations you have to report in the beginning. That includes human subjects research, animal care and use, and so on. And technology transfer that is conducted at the NIH in the intramural program. And as Ann just told you, the intramural program as a whole has about 10%, a little more than 10% of the NIH budget. And that differs considerably from institute to institute. Now, in addition to our site here in Bethesda, we have programs at the Rocky Mountain Laboratories. NIAID has programs in Montana. In Phoenix, Arizona, we study diabetes in the Pima Indian population. There's a perinatal unit in Detroit, Michigan. The Aging Institute and the Drug Abuse Institute are in Baltimore. There's the Environmental Health Unit, which is in NIEHS, which is Research Triangle Park in North Carolina. And we have laboratories in this area, including Frederick, Maryland. In toto, we have over 1,000 principal investigators, or 1,000 independent laboratories, with more than 5,000 trainees, and a total of more than 12,000 staff in the intramural program. 24 of our 27 institutes have intramural programs, and so you can imagine my job, which is to sort of keep track of what's going on and hopefully make sure people are heading in roughly the right direction, is a little bit complicated. And it is rewarding, however, to have an opportunity to work with each intramural program as they develop their specific kinds of requirements. And I must say, it's important to me that the institutes take advantage of what is relatively long-term funding in the intramural program, very specialized resources in our clinical center and in our laboratories, and amazing opportunities for collaboration throughout the intramural program. So I would say with great enthusiasm that NINR really hit the jackpot when it came up with the great idea of developing a Symptom Science Center. And I'd like to tell you a little bit about my perception of that center, which I think is really a relatively unique and important contributor to the intramural program as a whole. So the idea is that through better understanding and management of the symptoms of illness, such as pain, fatigue, or depression, the Nursing Institute is poised to lead the NIH on its path towards precision health. One of the earliest discussions that I remember having at the NIH, and I have to say I've been in this position for 25 years, so I'm one of the more senior folks at NIH. One of the questions that came up, and it was asked by Jim Weingarten, who was the director at the time of the establishment of the Center for Nursing Research, was what was nursing research? What really is it? Many people, including the director, were not convinced that there was such a thing, a special thing as nursing research, that NIH was much more focused towards basic science and cures-devoted research. And I would say that the scientific directors were also a little skeptical about nursing. But the Nursing Institute really, over the last 10 years or so, has developed a very clear vision for nursing research, manifested through the Symptom Science Center, and I think has convinced everybody that this is really both appropriate and a necessary direction for medical research at the NIH. So you shouldn't be surprised at the skepticism that the Nursing Institute was greeted with in the beginning. Think about Florence Nightingale and the Crimean War, or the creation of nursing accreditation programs. They were born in war. There have always been fights related to nurses and nursing research. Even now, there are some disagreements about certain things. But the Nursing Institute is triumphant and I think has demonstrated both good judgment and a really terrific direction for the Institute. To Dr. Weingarten's credit, and remember he was the NIH director at the time of the establishment of the Center for Nursing Research, he said that if NIH is going to have a Center for Nursing Research, it better be a good one. And so they invited a lot of really smart people to launch the National Center for Nursing Research. And I think he would be really impressed by what has occurred today. It's a pity he can't be here. Unfortunately, he died just a few months ago. To me, the Nursing Institute has been a crucial link between the search for cures and the delivery of treatment, fitting in the model of bench to bedside and back again that we hold within the intramural program. This missing link became obvious during the rise of AIDS. Quite organically, the National Center for Nursing Research leadership recognized the need to provide better care for AIDS patients. AIDS is a disease in which symptoms wax and wane, unlike terminal cancer, which tends to be a steady decline in patients' health, and required special attention. This need to treat the AIDS patients who are here in the appropriate way translated into a collaborative intramural research program working with NIAID and the NIH Clinical Center Department for Nursing, which led to really improved care for the AIDS patients who are being seen here. The National Center for Nursing Research also struck up collaborative agreements with the Cancer Institute. Cancer patients obviously undergo grueling treatments. They have a lot of symptoms associated both with their tumor and with the treatments they get, as well as dealing with the anxiety of sometimes what is a terminal diagnosis. Very little scientific research had been done to try to understand how to mitigate these problems. Today, as a result of nursing science, we have far better care for the side effects, which in turn has led to improved recovery rates and prolonged life. It's well known that a patient who feels well and has a positive attitude about recovering from their disease does better. In contrast to most NIH institutes and centers, the NINR's mission is not focused on any particular disease or organ system, and yet we'd be hard-pressed to name any clinical program at the NIH that doesn't benefit from nursing science. With the creation of the Symptom Science Center, the Nursing Institute is essentially making it easier for the broader NIH to tap into their expertise. And we know that NIH clinical research frequently seek expertise from NINR in dealing with symptoms. And so in 2013, the NINR convened a workshop of experts in the field of symptom science to propose and discuss a series of research questions that could help the Nursing Institute and the NIH better integrate symptom science into clinical research. So this was the result of a very deliberate and I think important strategic process. In reviewing what those questions were, I think they're quite engaging, and I'd just like to mention some of them to you. The first is, what are the biological and behavioral dynamics of symptoms? For example, dyspnea, fatigue, impaired sleep, insomnia, pain, depression, that can change the trajectory of chronic illness? And how can the dynamics be managed and maintained to prevent symptom relapse? Second, what innovative care delivery models, research methods, and technologies can be leveraged to improve symptom management and change the chronic illness trajectory, especially among individuals who experience disparate health outcomes? How do symptom precursors, for example, biomarkers or conditions such as obesity, contribute to the physiology of symptom risk, severity, duration, and response to treatment. Such basic questions reveal, perhaps surprisingly to some, how little we know and how much nursing science can contribute. The knowledge gap has been astonishing, and it's now being filled by the Symptom Science Center. Core functions of the NINR-led Symptom Science Center would be to standardize assessments and treatment outcomes and to predict patient-related clinical outcomes. They have quite a few tools, and some of them actually have cute acronyms, and so I'd like to remind you of those. You may be more familiar with these than I. Patient-reported outcomes are called PROS, P-R-O-S, as opposed to poetry, I guess, but which have grown out of the NINR pain research portfolio. PROS include reports of pain, fatigue, physical functioning, emotional distress, and social role participation. There's computer adaptive testing, or CAT, C-A-T, which is part of a framework for symptom assessment and collection of PROS developed by NINR. The CAT can improve patient reporting and reduce respondent burden because, from the patient's point of view, the difficulty of the questioning seems to tailor itself to their ability to answer. And just as an aside, we've all heard of therapy dogs. This is the first time I've heard of therapy cats. There's also the Patient-Reported Outcomes Measurement Information System, or PROMIS, born of the NIH Common Fund. The promise of PROMIS is to provide the clinical research community with a rigorously tested PROS measurement tool that uses recent advances in information technology, psychometrics, and qualitative, cognitive, and health survey research. So you can see this is a very sophisticated set of tools that are used to assess symptoms in order to move the science forward. With the skillful use of these tools, the Nursing Institute can help the NIH intramural program meet several of our long-term goals, such as to develop and deliver personalized medicine and cell-based therapies, and to overcome drug resistance, to combat inflammatory diseases, among other elements of the long-term planning. It's a tall order, but the Nursing Institute Division of Intramural Research, as modest as it is, and it's quite small, comprises a dream team of nurse scientists. Leading the Symptom Science Center, and I hope you've met him, is Dr. Leo Saligan, who studies the mechanisms of cancer treatment-related fatigue. Leo has a particular focus on mechanisms of fatigue associated with radiation treatment for cancer. In his research, he has identified markers associated with inflammatory pathways in patients with post-treatment fatigue. Wouldn't it be amazing if we could find a way to cure the fatigue associated with cancer treatment? Supporting Leo will be the research staff and research output of 4 NINR intramural branches, including the biobehavioral branch, the symptoms management branch, the tissue injury branch, and the advanced visualization branch. As you can surely visualize yourself, symptom science has clear relevance for cancer, neuroscience, genetics, immunology, pain addiction, health disparities, behavioral science, and other research topics in nearly every NIH institute and center. Numerous projects, which are collaborative, have been lined up already. So just in closing, I want to mention some other ways in which the Nursing Institute, in addition to the Symptom Science Center, has contributed to the environment, positive environment at the NIH. The Nursing Institute has a graduate partnership program and has hosted scores of PhD students who complete their coursework in an academic setting and come to the NIH to do research. The NINR has a Summer Genetics Institute, which is a month-long intensive program to train nurse scientists and nurses in advanced genetics so that they can become genetic counselors and help in what is really the future of personalized medicine in the United States. NINR has a methodologies boot camp, which is now in its 10th year, which is an intensive research training course held in the summer designed to increase the research capability of graduate students, faculty, and clinicians. As I understand it, this is a very popular and competitive program. And the NIR was the first to host a LASCR Clinical Research Scholar. The LASCR Scholar Program is a program at the NIH to bring outstanding clinical investigators to work in our clinics. They are on the tenure track when they come here. The very first Lasker clinical scholar at the NIH was Jessica Gill, who was an intramural scientist within the Nursing Institute. She has since been tenured in the intramural program and has done truly pioneering work in her studies on post-traumatic brain disorder and combat injury. Appropriately, she's moved on to some administrative tasks, hopefully not at the expense of her science, and has been recently been the deputy scientific director of NINR. And I think, is it okay to say she's going to be replacing Anne when Anne leaves as acting scientific director? We are really grateful for her willingness to take on important administrative tasks as well as her science. And I know that she will do a terrific job. The NINR has since recruited another Lasker scholar, Paulie Joseph, who studies the role of sensory science in metabolic disorders. And I should point out that we have 24 total Lasker scholars at the NIH, and 2 of them are in the Nursing Institute. Despite its size, it really has been a wonderful home for clinician scientists. And finally, before I close, I want to thank Anne Cashion. Her leadership has been extraordinary. She's been the scientific director and now acting director of NINR. And in both of those roles, she's done an absolutely terrific job. She's a member of the board of scientific directors, and as such, she really is always a person who has a really good suggestion. She's a voice of reason, and I think a very effective representative of the Nursing Institute at the table, which consists of other scientific directors at the NIH. And we will really miss you. Thank you.
Thank you very much, Michael. I appreciate you presenting, and I would like to also say that over the last 10 years, we have really been impressed by how well you've been able to speak about our science. So thank you so much. Do people have questions, or do you have time? I know Dr. Gottesman actually has a 1 o'clock meeting that he has to go to. But
if there are questions, I'm happy to answer them. The question is, how does that fit in with your schedule?
No, you can ask. There can be, if anybody has any questions.
So if there are questions about the intramural program. Okay.
Thank you very much. In deference to Dr. Gottesman's schedule, we changed our schedule a little bit, so I'm going to sort of go backwards at this point and also introduce Dr. Tara Sweats. She is sitting here with us today. As I know all the council members are aware, and NINR staff, Dr. Sweats is now our acting deputy director. She has been here at NIH for 8 years? Around 7 or 8 years. She actually has worked in NINR at one point in time, but has moved on through various positions into the NIH Office of the Director, where she now is the deputy director for Dr. Tabak. So Tara is here today to learn about our council, to really meet our members, and also to learn about, to answer questions as we go forward. So Tara, do you want to say anything at this point?
So good afternoon, everyone. Thank you. Thank you for the introduction, Anne. It's really a pleasure to be here today. I'm excited to go around and meet all of you in person. Some of you all we've talked to on the phone. So as Anne mentioned, I'm Tara Schwetz. I'm the Associate Deputy Director of NIH, and for the time being, I'm also the Acting Deputy Director of NINR. And it's a real pleasure to be back at the institute in which I started my NIH career at. So I'm excited to get reacquainted with the science and all the work here that's being supported here at NINR. And as I said, hopefully, interact with all of you over the next couple days. Over the last couple weeks, I've had the great pleasure of working very closely with Anne and also getting to know all the staff here at NINR. And I will just echo Michael Gottesman's sentiments that we will truly miss Anne when she leaves. We really tried hard to get her to stay, basically everything except for chaining her to the desk. But, that's not out of the question yet. I'm just kidding. But you gave me a little bit of hope maybe with that comment about staying for the 100th council. Maybe we can convince you. Okay. All right. It was worth a shot. I had to take it. But, all kidding aside, we do wish you the best of luck in your new adventures. And it sounds like she's got some really exciting things planned and in store for her. But in the meantime, we're pushing forward with our search for a new permanent NINR director. And NIH leadership, including both Francis Collins and Larry Tabak, are really invested in and engaged in finding the right candidate from the nursing science community to lead this really important institute. And so, we encourage folks to share the information about the job announcement, which I think we have some flyers, and it's going to be in the slide set. So please share that with anyone that you think may be interested and a good fit for the position. Consider applying yourselves maybe. But in the meantime, the Institute, its mission, its function will remain largely unchanged. And NINR's capable staff, who are all sitting around this table in the outer edges of this room, they have proven over the last year that they can sort of stay the course while we're in a transition period for leadership. And so we applaud all of their efforts and know that they'll continue the important work that NINR is doing. So I look forward to hearing your thoughts and the discussion and presentations today, and working with you all further over this transition period. And as I said, I hope I get to interact with you all over the next couple of days. Thank you.
Thank you, Tara. Also, Dr. Larry Tabak, who will be the acting director beginning October 1st, he will be here later today, and we can particularly have a discussion at that point in time. But if anybody has any questions at this time for Tara, we're happy to entertain those as well. So, again, good afternoon and welcome to the 99th meeting of the National Advisory Council for Nursing Research. Let's see. How do I move it? This one?
Yes. That's the big one forward.
Oh,
That's better.
perfect.
It's a digital pointer right there if you hold it.
Thank you very much. So we're going to, I'm pleased to announce that today's meetings and all future council meetings will be webcast. So just keep that in mind. I know, having watched webcasts before, that people around the table forget they're being webcast. And so you start doing things. So just try to keep in mind that a camera is on you all day long. So this is the warning. And I will be the worst offender of this, but just putting it out there, that you are being recorded and shown live right now. So I'm going to, as Tara had already said, we are seeking applications for exceptional candidates. Applications are due by Monday, November the 18th, 2019. Nathan, there are flyers here, right? No? Okay. There is a web link that is on this particular page that shows you where you can go and read about the search. And please, one of the advantages, some of you may be aware that there are a lot of tweets out there and there's been a lot of emails going around. One of the advantages of that is that it is real, people are out there talking about this job, and that this type of promotion of this job, you can't buy. So we are very pleased that they are tweeting now about this search, and we do encourage individuals to apply. Just briefly, let's see, I'm retiring September 30th. It is, I should have counted the days because y'all would have laughed, but it's like a week and a half from now. And for the past 8 years, I've really had the privilege of being here. And it's been a fantastic 8 years for me. Working as the scientific director has been quite a privilege to start understanding all of the opportunities at NIH, the research that goes on, making the collaborations. You don't have this opportunity at any university or anywhere else, I would say, in the world. So it is a fabulous job to be here. And I'm very, very pleased that I had this opportunity to be the acting director as well. I do have extreme confidence in the incoming transition team. I think they're going to do an excellent job in steering us or continuing the course that nurse scientists have already defined. And not only that, Larry Tabak, who is the incoming acting director for NINR, is currently the principal deputy director for NIH. So basically, he's the right-hand person for Dr. Francis Collins. So for nursing science, this allows our science to be known even more about that at some of those tables that we have actually not been seated at in the past. So I think that this is our opportunity to actually make sure that leadership is very much aware of the excellent science that we're doing, what we're funding, and that this will be a wonderful opportunity for us. So please just keep some of those points in mind as we go forward. And as Dr. Gottesman already kind of said, I'm very pleased that Jessica Gill will be the acting scientific director. I think she is well ready to do that. She's as the deputy director, deputy scientific director over the last year. I must say that I have leaned on her heavily to do most of the work in the intramural program. So she's already been there. She's been doing it. And I'm very pleased now that she's willing to continue to do it, that we didn't burn her totally out during that year. So thank you. I look forward to seeing how the program continues to grow and thrive under your leadership. So you'll recall that in May, we introduced our newest council members, Dr. Wolf, Lewin, and Lowe. Dr. Lewin was unable to be with us, but is here with us today, so we welcome him, as well as Dr. Unuk M, who is here joining us today as well. So now a little bit on the budget. It's a daily guess. But this is our retrospective budget over the last 3 years, so 2017, 18, and 19. The key points I like to illustrate is that NIH has gone up each year, 6.6% in 17, 8.8% in 18, and 4.7% in 19. And NINR has gone up as well each of the consecutive years, which is wonderful. And I would certainly attribute a lot of that to Dr. Francis Collins and the bipartisan support that we get in Congress. A reminder that NINR's budget is appropriated, comes directly from Congress, so the amount that we get is not determined by Dr. Collins or by anyone in the office of the director. It is a appropriation from Congress. So some people will ask me, well, why is it 4.7% to NIH and NINR only got 3.1%? It's because there are programs that are funded in the NIH budget that doesn't go to any institute. The All of Us research programs is examples, some Alzheimer's funds are examples. So there are funds that are out there, and so that's why you see the discrepancy or the difference in some of those numbers. But we are very pleased right now. Congress, the representatives have voted us to get more money again this year. The Senate has been there's been some controversy in the Senate, and so it has not been voted on. So what is going to happen? Our budget, just as a reminder, our budget ends at the end of September. So there may not be a coincidence that I'm leaving on the day that the budget ends. It may be a very thoughtful decision or not, but it ends on September 30th, and exactly what will happen after that at this point we don't know. One thing is called a continuing resolution, a CR, and that is the expectation is that we will get a CR for several weeks or a month, and that just means that our budget remains the same and we continue to function. The other would be something that we have experienced in the past and we know how to handle, is that the government would shut, or at least our part of the government would shut down at that point in time. So both things occur over time, and we have certainly experienced them. I'm not worried about either one, but just to answer your some questions that you may have about our budget. I hope that we're going to see ultimately an increase in our budget again for this year. So that's my hope. Because that actually translates to more funding that we can give our investigators. And so that's a wonderful opportunity for us. So here is how our budget is divided up. The key points here are that about 80% of our funds go out to fund extramural research programs across the United States. That's what RPGs are, research program grants, RPGs. It includes our center grants, which you see at 4% for our P20s and P30s. Other research, that's our palliative care network. RMS is sort of the administrative cost. Training is very important to us, and we do 5% in there. And research and development is more along the lines of some contracts that we have and that we need to maintain as part of NIH, is an institute at NIH. And then intramural comes in at about 8% of the budget. So this is showing you actually more information about our training and our commitment to training. I like to point this out. Oh, look. We're the blue, and you see that we have about 4%, almost 5% of our budget goes to training. The only other institute that has a higher percentage that goes to training is NIGMS, which is medical science, and their mission is primarily training. So that's why they have a higher percentage. But it's always been a very important for us to fund our nursing scientists. We are still a younger profession in terms of research, it's a younger scientific profession, and so we feel like this amount of training is important to give our researchers. And we have gotten wonderful results from the amount of money that we've spent with training. We're very pleased. And now an update from NIH. You heard Dr. Gottesman talk about Dr. Weingarten. He was the NIH director. He passed away earlier this year, and as Dr. Gottesman was saying, Dr. Weingarten was very involved in HIV and the beginning of the care or the research in that area, and that also nurse scientists were very involved as well as we developed our center and started to grow. So he has been important to NINR over the years. Another death in the family is Dr. Donald Lindbergh. He was the National Library of Medicine director, and he died on August the 16th. He was more than 30 years as the director of NLM. So he kind of brought NLM into the current internet phase. He embraced the internet. He gained new and improved access to the medical literature via PubMed and PubMed Central, clinicaltrials.com, and consumer health information via Medline Plus. So many of the things that we think about with the NLM were begun during his leadership. Another, let's see, the All of Us program has made, I want to speak just a little bit about the All of Us program. It's made some strong progress over the last year, and recently in a New England Journal of Medicine paper, it reported some of the outcomes. So over 230,000 people have been enrolled. I think particularly interesting to us as nurse scientists is that 80% of those enrolled are from groups that have been historically underrepresented in biomedical research. And from when I was not as part of NIH and I sat on some of our study review groups, I know that many nurses are involved in trying to really look at health disparities. And so the fact that there is so many different groups, underrepresented groups in this cohort of individuals is important to us as we begin to think about the science that we want to conduct using the data that's being collected by these individuals. So please keep this in mind. There's still, the plan is to get over 1 million people in this diverse cohort, and they will have lifestyle data as well as genetic data and a lot of mobile health data as well. Dr. Gottesman actually spoke about a lot of the things I'm touching on today as well. We will be sunsetting the Promise program. It's been something, again, that nurses have used in their research. It ends at the end of fiscal year 19, which means in 2 weeks, and it will transition from the Common Fund. And it's been a 10-year project. Numerous NINR and NIH grantees have utilized this over the years. In June, NIH issued a notice about expanding usage of notices of special interest. So this is something new. Notices inform the extramural community that NIH is expanding and formalizing the use of notices of special interest. NOCs is what they're called. They're posted in the NIH Guide for Grants and Contracts to announce interest in specific scientific research topics. Currently, NIH has a large number of non-parent program grants, PAs, with standard submission and review requirements that vary from one another only in the scientific topics highlighted. So these PAs will be phased out over time and will be replaced with notices of special interest that direct applicants to use one of the parent or other existing announcements for submission. This change does not diminish the interest in these scientific topics, but rather it simply streamlines how NIH interests are announced. So it's just a change. NIH will continue to post full funding opportunity announcements, FOAs, for requests for applications, program announcements with special receipt, referral, or review considerations, and program announcements with set-aside funds. So we've been talking about this for a while. We will continue to talk about it because it is confusing. And any questions that you have, please do ask our intramural program officers or our extramural program officers, or leadership, and we will make sure that we completely answer questions as they arise. NINR frequently partners with other NIH ICs to support research endeavors that cross traditional boundaries. Examples of 5 current trans-NIH funding opportunities in which NINR participates include research on health of transgender and gender non-conforming populations, environmental influences on aging, applying a biopsychosocial perspective to self-management of chronic pain, dissemination and implementation research in health, and mechanisms underlying the contribution of sleep disturbances to pain. And now news a little closer to home, news about NINR. Ada Moore, Kai, we're very pleased that she is now the new dean for the University of Arizona College of Nursing, and congratulations on that. I saw many of you at today's NINR Director's Lecture. That was a wonderful presentation by Dr. Jean McSweeney on cardiovascular symptoms in women primarily. Our next director's lecture is November the 19th, and it will be Dr. Patricia Stone from Columbia University. She's a leader in research seeking to understand the complications and rigors of conducting real-world comparative and economic evaluations in the context of improving the quality of care and specifically preventing healthcare-associated infections. So I'm sure it's going to be an excellent presentation. I have heard her present numerous times. NINR supported investigators, Dr. Sarah Rossetti and Tracy Yap, were among the scientists and researchers named as recipients of this year's Presidential Early Career Award for Scientists and Engineers. It's called the PCASE Award. So we're very pleased that two of NINR's scientists were included in this group that were awarded this year. So it's the highest honor bestowed by the U.S. government to outstanding scientists and engineers who are beginning their independent research careers and who show exceptional promise for leadership in science and technology. Dr. Gottesman has already talked about the Symptom Science Center a little bit earlier, but I do want to say we did have a launch of it in June 27th, 2019. It just went so well. And a video of the launch is now available on our website, and you'll be hearing more about the Symptom Science Center from Dr. Leo Saligan later this afternoon. So as acting director, I was an invited panelist at the Chicago Town Hall meeting convened by the Committee on the Future of Nursing 2030. Just to remind y'all that the National Academy of Medicine is doing a new Future of Nursing report, and they've had 3 town halls, or having 3 town halls to gather data from around the country, and each town hall has a specific focus. I was having read the last Future of Nursing report and looking at some of the objectives and goals for the 2030 report. I was really interested in trying to promote the use of science and the role of nursing science in this report, that it primarily discussing how it underpins our clinical practice and how we want to utilize the science. So I was so pleased that they invited NINR and me to come to the town hall and actually give our talking points and talk about that, and it was very well received. So strengthening right now we're having a 2-day workshop on strengthening the impact of community health workers on HIV care and viral suppression in the U.S. And as far as I know, and Rebecca, I'm looking at you, it's still going well. It's not going well? Oh, it's done. Okay. Good. It's done. It went well. Let's just say it. But yesterday I was there to present and really talk about, we're doing this in conjunction with the Office of AIDS Research here on campus. And they did some money. We did a lot of the legwork, and we had these excellent presenters come yesterday and today to talk about community health workers and their role in the next phase of care and clinical practice and research for HIV and AIDS patients. So it has gone well. We actually were very pleased that Dr. Sylvia Trent Adams, the HHS Principal Deputy Secretary for Health, could actually join us, and she presented, and it's one of her passions as well. And most importantly, as I stated yesterday, she's a nurse as well. So it's good to have that leadership in that position. So hopefully the work that was put into this will bring great outcomes in the future and really improve the health. So NIH National Research Service Awards, the NRSA, individual fellowships, F31s and 32s, and institutional training grants, T32s, allow recipients to receive training in clinical research. So NINR has produced a short guidance document summarizing the specific instructions for applicants who are proposing to gain this clinical trial research experience. So applicants who are doing this in their training awards need to review the guidance document and follow the instructions. You know, as a reviewer, we always say if they couldn't follow instructions, how can they be a researcher? But follow the instructions and for this relevant funding opportunity announcement. The document may be found using the link listed on the slide. And I'm sure we can also have it available on our website as well. And additional information is available from the NIH Extramural Nexus. Dr. Jerry Miller is the acting deputy director for our extramural program and chief of the Office of End-of-Life and Palliative Care Research. We're very excited because she's been asked to be the non-sponsor federal partner, or NINR has been asked to be the non-sponsored federal partner, and she is going to represent NINR in this Congress-requested report. And the Agency for Healthcare Research and Quality is bringing appropriate groups together to look at hospice and palliative care and develop and disseminate information for patients, families, and health professionals about palliative care. So Jerry is extremely knowledgeable about this, has been working with this community for many years, and her expertise has been recognized and sought after. So we're very pleased that they have included her and the work that we are doing and in developing this. So they're using a systematic review process to demonstrate benefit of patient access to palliative care and the interdisciplinary services provided to patients by professionals trained in hospice and palliative care. They plan to have that report out later this year. And also, we're very proud of our own palliative care research cooperative group. I'd like to highlight some of their activities this year. The Palliative Care Research Cooperative Group has committed to serving as a section editor for the methodological review section of the Journal of Pain and Symptom Management. They are also doing a couple of symposiums at the 2020 European Association of Palliative Care Research meeting, and they're developing and disseminating evidence and consensus-based family caregiver outcome measures. So again, it's recognition of some of where we have put our emphasis over the last several years and using this expertise to improve health outcomes. In August, NINR released 2 new NIH funding opportunity announcements that encourage research to determine the requirements and best practices for palliative care in home and community settings. And these funding opportunities are provided under R01 and R21 grant mechanisms. They're first due in October of this year, and they'll be open for multiple years. And now just a little bit about 6 science funded programs that we support and what they are finding. So in the area of women's health, a single site randomized clinical trial tested whether cognitive behavioral therapy for insomnia improved depressive symptoms, maladaptive thinking, and somatic hyperarousal in postmenopausal women with insomnia. The study compared the cognitive behavioral therapy to sleep restriction therapy, and also had a control arm that was just sleep hygiene education. While no durable treatment effects were produced with sleep hygiene education, the cognitive behavioral therapy and the sleep restriction therapy reduced depressive symptoms, dysfunctional belief about sleep, and pre-sleep somatic hyperarousal in postmenopausal women with the cognitive behavioral therapy producing superior results. So we're excited about that. Another study focused on identifying latent subgroups of self-reported cognitive problems among postmenopausal women with and without breast cancer. It explored associations between membership in these subgroups and their demographic, clinical, and symptom characteristics, as well as variations in candidate gene polymorphisms. 3 latent subgroups were identified, more frequent, persistent, and almost never. Receipt of chemotherapy plus the anti-cancer hormone therapy, depression symptoms, and baseline neuropathic symptoms increase the odds of belonging to the more frequent subgroup. Anxiety and depressive symptoms increase the odds of belonging to the persistent subgroup. In addition, so when we're looking at the genotype, ERCC5 increase the odds of reporting more frequent cognitive problems. So looking at combining the symptoms with the genotype and seeing if we can come up with some ways to identify who will respond to treatment is a very important area for nursing science. So in the area of sleep, a pilot study tested an intensive care unit sleep promotion protocol that restricted non-urgent bedside care overnight. Having been an intensive care nurse for about 4 years or longer, I know and worked many night shifts. I know I woke up my patients a lot at night, and you did always wonder, what was the unintentional effects of that. So this particular intervention had 32% fewer room entries, and they saw 9.1 fewer minutes of in-room activity. So the intervention group also had sound levels that were 2.5 decibels lower. So overall, the intervention decreased in-room activity and sound, which provides better opportunity for sleep. And I think that's a good thing. Just a few more, so you'll know what your dollars are funding or what the decisions that are made around this table are funding. So a few advances from the area of preterm infant care and also cardiovascular health. So in the preterm infant care, you have a randomized single-center clinical trial. The value of measuring gastric residuals in preterm infants was examined to determine the effect of omitting the pre-fed gastric residual evaluation on nutritional outcomes. So basically, it's making a decision to not do an evaluation before you do the feeding. And by comparing the omission of this evaluation with pre-fed gastric residual evaluation, the study found that among extremely preterm infants, the omission of gastric residual evaluation increased the delivery of interim nutrition, or what they were able to take in. It improved weight gain and led to earlier hospital discharge. So another example of really trying to affect practice. Another study in preterm infants investigated the impact of early life stress on the trajectory of gut microbial structure, and they found that in NICU, stress exposure had a significant effect on the type of microbiome that the individual had. And the findings suggest that early life NICU stress may significantly influence the developing gut microbiome, which is important to the practice there as well as to future microbiome research. And lastly, in the area of cardiovascular health, a study was conducted to identify predictors of health status in a sample of racially and ethnically diverse patients with heart failure using a web-based mobile health application. Using a cross-sectional study at an urban academic center, patients with heart failure self-reported symptoms by way of the mobile health application. Predictors of better health status and health failure included higher physical function and ability to participate in social roles and activities. Predictors of poorer health status were New York Health Association Functional Class 4 and dyspnea. Patient-centered interventions should focus on modifiable risk factors that reduce dyspnea, improve functional status, and enhance engagement in social roles to improve the health status of patients with heart failure. So those were just some select examples, and here's some select NINR funding opportunity announcements. including improving individual and family outcomes through continuity and coordination of care in hospice, symptom cluster characterizations in chronic conditions, new onset depressive symptoms in acute illness, addressing chronic wound trajectories through social genomics research, and end-of-life and palliative needs of adolescents and young adults. Now, to switch just to training, the 2019 Summer Genetic Institute was held in June. It's still a 1 month long institute. Dr. Yvette Conley, who's our council member, is very involved in that particular activity here, and we appreciate all that she brings to that. This year's class included 26 participants from representing universities from across the country and brings us to over 400 graduates since 2000 who are making a difference in communities across the country. The application period for the 2020 SGI will open mid-November and closes in March. The Precision Health Smart Technology Smart Health Symposium was our NINR Methodologies Boot Camp this year. You can see there were a lot of people there, and we were very, very pleased with the outcomes this year. It addressed digital health data and smart technologies. And in addition to featured speakers this year's boot camp included a panel session on the All of Us initiative and poster presentations. Our Division of Intramural Research 2019 Summer Trainees are a group, are pictured here. The summer interns conduct their research for 8 weeks. Some trainees were at NIH training programs from NIH training programs such as the Community College Summer Enrichment Programs and the Graduate Summer Opportunity to Advance Resource. Earlier, Dr. Gottesman also mentioned the Graduate Partnership Program. Its application period is open now. This is a wonderful opportunity for universities around our country to do the didactic training at their home university, and then the student will come to NINR to do their dissertation within the labs here. It's what I have seen is that those individuals who take advantage of this program are very successful following the program. We have great outcomes from this program, so I highly recommend that people can look at this and consider doing this. NINR was represented by 11 trainees at the NIH Postbac Poster Day. Some people ask me, what's a postbac? It's not normal in a university setting to have postbacs. NIH has many postbacs because NIH has a very strong training mission. A postbac is an individual who has a baccalaureate degree and comes to NIH to work in research labs for 1 to 2 years. It's limited to only 2 years. At the end of 1 to 2 years, they have applied to a graduate program and will go back to school at that point. So some people in our postbacs, we usually hire a number of postbacs. Let's see, this year, wow, looks like we have about 10 or something. 11, I already said it, sorry. 11, so some will go to, we've had clinical psychology, people who are interested in clinical psychology, nursing, med school, and many of the biological PhD programs as well. A little bit about the NINR staff news. I'm pleased to acknowledge 4 outstanding staff from NINR's Division of Extramural Programs and Division of Intramural Research who were recognized at the 2019 NIH Directors Award ceremony held in July. So this is a big deal here on campus. So we were very proud of Dr. Michelle Hamlet, who received 2 awards for her work on the NIH-wide effort to restructure the R15 Research Enhancement Award, and also for her work with the All of Us Scientific Priorities Development Team. Dr. Martha Matoka and Brian Wallet each received an award for their contributions to the trans NIH myalgic encephalopathy. And now I never say all of that right. Encephalomyelitis. I think that would do. Chronic It's chronic fatigue syndrome is the other MECFS working group. Dr. Rebecca Rasuli received an award for her work on the Include Project leadership team to develop and launch a trans NIH initiative addressing the health and quality of life needs for individuals with Down syndrome and its co-occurring conditions. So please help me in congratulating Drs. Hamlet, Matoka, Wallet, and Rasuli. Yay! Very good, very good. NINR's Division of Science Policy and Public Liaison has prepared a handout regarding our recent outreach efforts, and this handout has been provided to council members, and copies are also available at the table on the front door. And I believe I now see our posting our job announcement for the director. So it's very, see, it's nice being the acting director. You ask for something and it just appears. Thank you, Nathan, very much, wherever you found them. Thanks for doing that. So again, I want to express my appreciations to all of you for being here today. I think it's going to be a wonderful afternoon, and we will be getting started shortly. I'm not sure if you start right now or if I have some more announcements to do, so I apologize for that. Let's see. Yes, let me introduce you. Okay. Yes. So our next presenter today is Dr. Jessica Gill, who I've introduced numerous times. The part that I would probably like to emphasize here is that she is tenured here at NIH, and her work has involved biomarkers for traumatic brain injury, and that's where her science has really been built. She is a wonderful collaborator, and because of her joy and experience with collaboration, she's been able to build some of our science program with other institutes, which really does leverage our abilities and what we can do, as well as with other agencies. So at this point in time, Dr. Gill, go right ahead, Jessica.
Great. Thank you so much, Ann. That might be the last time you introduce me, so I appreciate it. So today I get the pleasure of talking a little bit about what's going on in our intramural program and some of the changes and where we're going with those. So really the focus of our intramural program is to undertake studies to understand the mechanisms that underlie the development of symptoms both acutely as well as chronically. How can we understand the nature of individual variation, including genetics, diet, exercise, and other types of things that can impact an individual's health? How can we understand the mechanisms and then find modifiable factors that then we can intervene on to overall improve the health and well-being of the patients we serve? Our mission here is greatly enhanced by the activities of the clinical director in the clinical director office, which is Sue Wingate, who I don't see here today. But her office basically helps us with instrumenting all of our protocol activities from the beginning of an idea of a protocol to its implementation, to undertaking it safely, to doing the most productive science that we can with the resources we have. Included in her office are research nurses who are just amazing and make our lives easy here, or at least as easy as they can be in the federal government, as well as oversight for quality management in all components of clinical trials. We've heard a lot about training. Dr. Pamela Tamez is also instrumental to all of the work we do here at NINR. Training is one of our big priorities, and so all of the teams integrate trainees at all levels, from high school students up to postgraduates, including postdoctoral fellows and research fellows. This is something we take great pride in and great effort to provide a training environment that's optimal and to really help individuals get the training in translational science to be able to do that work here and then also promote it across the country and across the world. Some of the recent advances, we have our first Robert Wood Johnson Fellow here that just started, so we're excited to have that. We've also talked about the Summit Genetics Institute as well as boot camp. I think it's nice to highlight that this is the way that intramural programs also bridge with extramural to find ways to work more together to make the most of nursing science And so we look forward in the future to developing additional abilities to collaborate and to bring additional individuals here and to partner with you and to provide service and training to those individuals in nursing science. We've heard a lot about Leo Saligan, who is here, and our Symptom Science Center, we had our kickoff, which was very successful. We had about 300 individuals attend in person, and then we've had about 600 individuals watch the video cast. So that really goes to show how much excitement is coming behind this, and I think how much it can really change the way that we look at nursing science. And so Dr. Saligan is the perfect person to be designing this and moving it forward. I worked with Leo. We actually started as postdocs on the same day a little while ago. I won't date us. But seeing him move forward in his scientific career and really lead this huge effort is amazing to see, and we couldn't do it without him. Overall, you'll see this again, I believe, but really this is a symptom science model, which is the foundation of what we do here at NINR. What we do is we look at a symptom or a set of symptoms that are often comorbid to understand the nature and the experience of that symptom to the patient, their families, and their communities. We characterize that to really look at the severity as well as the type of symptoms to understand its impact to the overall health well-being of that individual. We then undertake studies to understand the biomarkers that contribute to the development of it, as well as the maintenance of that symptom and deficit, to really understand the mechanisms that are underlying both the development as well as chronic symptoms over time. This allows us to identify therapeutic targets or interventions that then we can introduce to modify or change these risk factors to overall improve the health and well-being of the patients that we care for. We also have Dr. Polly Joseph, who is in the audience also. We're excited to have her here as the second Lasker Clinical Scholar. She's also bridging, and she's a key collaborator within many, many institutes here at NIH, exemplifying the ability of nurses and nursing research to really go across the lines of institutes and do powerful research here on the NIH campus, which has been well recognized. She is now also with the National Institutes of Alcohol and Abuse and Alcoholism, to again provide a bridge of nursing science to do this type of work. The overall program that she's designed and is implementing here at NINR is to look at the neurological and molecular mechanisms that are related to symptoms with sensory experience, and especially to apply this to metabolic disorders, to better understand mechanisms that relate to the development of type 2 diabetes as well as obesity. One of the many publications that Dr. Joseph had this year is pictured here. What she did with the collaborators was to show differential neural activation of areas in the brain in those individuals who are more likely to develop obesity. Again, giving us ideas about how we can change this and how we can link sensory function to changes in neurological function, really highlighting the ability to do this collaborative research here at NINR. Polly has also been involved with another exciting training initiative, the NIH African Postdoctoral Training Initiative. And so we've had one of the fellows come in, and he also was able to attend SGI and really make an impact. Diversity is one of our key components here, and Polly always is our advocate for diversity, trying as much to really challenge the way that we see it and how we can be the best scientists possible. My area is the tissue injury branch. What I look at are concussions and traumatic brain injuries. What we know is that these are common injuries in the lives of Americans as well as people around the world. But what we don't know is why some individuals will have similar injuries and be just fine, whereas others will go on to have lasting symptoms and consequences. And so the focus of my lab is understanding that nature of individual variation so we can identify those individuals early who we need to intervene with, who we can follow over time, and then prevent additional exposures if needed. So this is a highlight from one of our studies that we just completed. This is with NCAA Care Consortium, which is the largest concussion study to date. We had about 40,000 individuals within this study. We're now going on to the second phase of the study, where we follow these individuals as they go into the workplace and begin families. This first phase was during collegiate play. What's unique about this is we get a sample before they're exposed to any type of collegiate exposure to sports-related concussion, and then we follow them over their 4 years in collegiate play. What we found overall using an ultrasensitive technology is that tau is significantly increased in those athletes who require a prolonged return to play. This is a replication of our previous study that was in neurology in 2017. And so it gives us an identification and replication of this finding. In addition to that, we also find that those athletes who need that prolonged return to play also have differential activity of a protein called GFAP. GFAP is one of the proteins that's been identified by the FDA to allow for the identification or the diagnosis of concussion in emergency rooms. So again, we expand on that. What's really important about these return to play decisions is that what we know is if an athlete has a concussion and then goes back to play too soon, they're about 7 times more likely to have another concussion in the next month. If they do have that concussion, they're much more likely to have non-optimal recovery and be those athletes that become symptomatic and compromised. And so having an objective biomarker that helps inform this very difficult decision can increase the safety of these athletes. As right now, what we do is we are reliant on their symptom reporting from them, from the coach, from the trainer. Most people want to get back. They want to be healthy. They want to play. But what we want to do is keep them safe. And so that's what we've been able to do through our collaborations. The last branch I'll talk about is the Advanced Visualization branch, led by Dr. Patty Brennan. She's also the director of the National Library of Medicine. I think everybody here at NIH has to have at least 2 jobs. So this is her second job, but we're very excited to have her with us. She's adding a depth to what we can do here at NINR. She now has a lab that's going to be functioning and being able to engage with patients and really add to what we can do. Overall, her focus is to improve patient safety through the management of engaging presentation of actionable health information. This is something that's not being done right now at NIH, so really adds a different component about what we can do. We've also had exciting development in our lab over the last year. Dr. Kim, who overall sees this and never comes to any of these meetings, but we really appreciate all the effort he puts in. Oh, he's here. The one time I said he wasn't here, but he's here. We appreciate all he does. He comes in on Saturdays when the freezers go down and has really been the hallmark, the foundation of developing a very novel lab. What's novel about our lab is we don't function on one type of biomarker, but we have a comprehensive ability to go across all the functions of biomarkers. So we can look at anything from genetic predisposition to microRNA to exosomes that allow us to get to central functions using peripheral blood. We challenge ourselves to really get the most we can out of the biomarkers that we look at within the fluids that we collect. And so it's really challenging the paradigm to do that. This year we've added RNA sequencing, specifically in single cell, as well as advances in exosomes. And so we encourage you to reach out to us. We're happy to share the data that we're generating, as well as the methods, and to help everybody partner together to do biomarker research. Lastly, we also have Chelsea Wagner, who's joined us, and I see her over there. She is a major addition to our lab. She's come in with amazing amount of enthusiasm, has cleaned up the entire lab, organized all of our freezers, all the things that we neglected over the last year. And so we're extremely happy to have her here. So as we change and evolve and we say farewell to Dr. Cashion, we look to the future and we're excited on what we're doing symptom science with a very innovative clinical infrastructure as well as lab to really look to the forward of nursing and what we can do to do the best science we can. And so we look forward to partnering with everyone to really build this program and to do training as well as research to really move nursing science forward. Thank you.
Thank you so much, Jessica. Great job. So now the only thing that's keeping you from your break in the poster sessions is we'll read a list of who is visiting today. I have to read them, right? Okay. So Valerie Adelson, Nick Uranus, Kathy Sedgwick, Lisa Blair, Emily Jenkins, Karen Parker, Mayo Minison, Yakin Jeskunar, May Topaz, Christine Weaver, Nada. Oh, I've never been able to see your last name, Nada. What? Luca Hatai. Zehu Zhang. Zailu Chow, Youngming Park, Pratum Yovang, Deanna Dixon, and they are all from different organizations, including Oncology Nursing Society to University in Turkey. We have some visiting us from Cedars-Sinai, as well as Columbia, University of Maryland, Johns Hopkins, and Kentucky, and Nova Research Company as well. So and the John Maylou Foundation. So thank you very much for being here, and we will now take a break and do the posters. We will start up again at 2:30. Investigator of 5 clinical studies that merge state-of-the-science methodologies to understand the pathobiology of complex symptoms. He is a sought-after speaker, both nationally and internationally, as well as one of our best mentors. So he just does an excellent job, and we're very proud of what he is doing. So Dr. Saligan, it's all up to you now.
Wow. Pressure. Well, thank you, Dr. Cashion, and appreciate everything, your mentorship and your leadership. Really, truly appreciate and that kind introduction. Very touching. But good afternoon, everyone. So my role is some of you have attended our June lunch, which was really very successful and very happy about it. This would be revisit the overview of the Symptom Science Center, but at the same time, I'm going to give you some updates of our recent activities. So one of the themes that is driving the NINR strategic plan that the NINR Division of Intramural Research is focusing on is symptom science, as what Dr. Gill has mentioned. Specifically, we're dedicated to conducting research in the molecular and behavioral mechanisms underlying symptoms. Through this process, we utilize different approaches that can capture the subjective symptom experience and explore individual vulnerabilities from symptoms affecting function, quality of life, and performance. So we use our discoveries to develop innovative clinical intervention that informs symptom etiology and optimal symptom management. You've seen this slide a few hours back, but this is the symptom science model, and I'm really excited that a lot of our PhD students that I have talked to and have mentored have utilized this model in their activities. So our focus in the Division of Intramural Research is guided by the symptom science model, which starts out by our awareness of a complex symptom, then our attempt to characterize the phenotype, and most of the time different phenotypes of a specific symptom, and use this characterization to explore biologic markers that are associated with these symptoms phenotypes. Then use preclinical or sometimes clinical approaches, oftentimes some proof of concept interventions to functionally validate the relationship of these biomarkers with the symptom of interest. To build on the work conducted within the NINR intramural program, we propose to integrate the symptom science model into the activities of the Symptom Science Center. We envision that the SSC would serve as a hub to advance symptom science and precision health. So we envision this NIH Symptom Science Center as a trans-NIH resource where interdisciplinary research teams assemble around common symptoms or a common symptom that affect the person's quality of life. We also envision that this can bridge and further advance a collaboration between intramural and extramural scientists to tackle symptom research challenges. What are some of the examples of the symptom science research challenges? One is the capacity to investigate symptom clusters and the synergy, to understand the synergy to link biologic markers with subjective symptom experiences of patients. So how we all started? We started with by bringing in Dr. Margaret Gray. Dr. Margaret Gray was tasked to ask around the country among intramural and extramural symptom scientists, experts, as well as those that have started different centers or programs similar to the SSC. So during 2015, Dr. Gray did that, went around and asked for input and advice and recommendation about the feasibility of creating such center within the NIH intramural program. So Dr. Gray concluded that there was a great deal of enthusiasm to develop such center. But at the same time, there was caution that there needs to be a clear mission and vision of the center. So on August 15, we gathered experts, both from intramural and extramural, to a round table and tasked these experts to establish the mission, the vision, as well as lay out specific objectives for the SSC. So it was concluded that the mission of the Symptom Science Center should be to promote the understanding of the biological and biobehavioral mechanisms of symptoms to improve patient outcomes. It was also envisioned that the Symptom Science Center should provide an integrated and foundational nexus for both communities, for both the scientific and clinical communities, to understand and quantify symptom experiences across the lifespan. It was laid out that the activities of the Symptom Science Center should focus on promoting discovery, as well as creating collaborative and interdisciplinary teams. It was also advised that this Symptom Science Center needs to develop and contribute to the Symptom Science Data Repository. And once that's established, we need to develop predictive and treatment models to help with risk assessment, as well as optimize our symptom management. And of course, the core and the heart of the Symptom Science Center needs to be expanding symptom expertise through mentorship. So in order to address and to meet this mission, the vision, and the objectives, we thought we need to build 3 pillars of the Symptom Science Center. And one, it needs to be patient-centered, and it also needs to utilize innovative technology, as well as embrace this translational science that serves as the culture of the NIH intramural program. So first, the innovative technology. In order to leverage the existing resources and systems of the NIH, particularly in the NIH Clinical Center, where we're collecting symptoms data through protocols across NIH, it was just logical strategy for us to strengthen our collaboration with the NIH Clinical Center Nursing Department. So through our chief nurse, Dr. Gwen Wallen. So through our collaboration, we utilize existing technological advancement that are already present and being used in the NIH intramural program. But we pushed ourselves and looked into and explored other innovative technological platforms to be able to create common data elements, to be able to standardize assessment of symptoms, not just within our studies in NINR as well as in the clinical center, but serve as a champion, as experts of symptom assessment across NIH. So we were receiving a lot of those inquiries now from across NIH, from different institutes, to ask about how do you assess symptoms, how do you assess health outcomes, which is really a great place to start for NINR Symptom Science Center. So the goal of using innovative technology is really to contribute to the existing Common Data Element Initiative of NINR. As a lot of us know, this initiative was brought about by the 2015 report, which emerged from the center directors meeting, recommended the need for data collected from NINR-funded studies to be stored in a repository. So back in August 2016, NINR approved the creation of a common data repository and named this the Common Data Repository for Nursing Science, or CDRNS. This CDRNS was spearheaded by the NINR extramural division. So we collaborated with our colleagues in the NINR extramural to provide a space for the NINR intramural to contribute to the CDE initiative and expand the CDE library. So with the staff of the Symptom Science Center, they've now expanded that, and we have about more than 3,500 common data elements in our NINR CDE library. Translational science, the other pillar of SSC, is to utilize and optimize the expertise, but also the resources of the NINR lab. The NINR lab space, as some of you have visited, and if you haven't, please reach out to us and we can do a lab tour of our space in NINR labs. The NINR lab has the expertise to conduct innovative approaches using omic technologies. We also have the ability to do much more functional validation using in vitro experiments. These efforts are also complemented through our trans-NIH collaborations through valuable access to NINR core labs across campus. In fact, one of the examples of these trans-NIH collaboration is our partnership with established animal core labs along in NHLBI, for example, who does a lot of metabolic experiments of symptoms, and NIMH, who has a huge behavioral core facility just to phenotype symptoms. And these collaborations have helped us to develop animal symptom models in order for us to advance our mechanistic investigations to understand central and peripheral underpinnings of symptoms. And of course, one of the valuable pieces of symptom science is the patient-centered clinic. I'm happy to report that we opened our clinic doors last week when we enrolled our first patient for our study, which is patient-centered assessment of symptoms and outcomes, or we call it simply as the Picasso study. And also I'm happy to report that a lot of studies are in the pipeline and different levels of review at the moment. So the clinic, the Symptom Science Center Clinic, serves as a hub for symptom phenotyping and management, often from patients referred from other NINR and NIH studies. We actually have a list of people and collaborators that are really excited to send their patients just to refer to our patients to be able to phenotype their different symptoms, particularly in fatigue, which is my symptom of interest. So it's a great opportunity for us to have these resources in order to dig deeper into the biology of symptoms, but at the same time, champion across NIH, be an expert on how to optimize our symptom assessment, as well as eventually the second phase is manage symptoms. So the clinic also functions as a venue for collaborative studies, for example, in pain, in sleep, and fatigability with rehab medicine, as well as training and building our data repository. In terms of expanding partnership, currently the Symptom Science Center is committed to expand through partnership with other institutes. For example, we've had high-level discussions with the National Center for Complementary Integrative Health. They have the hosting or establishing the pain center, so it was just logical for us to join together and join forces to be able to phenotype both symptoms in pain and fatigue. We are also partnering with other ongoing NIH initiatives, such as the All of Us initiative. And currently, just this month of September, we're already scheduled to have high-level meetings with other senior leadership of several organizations who are interested to partner with us in the Symptom Science Center. For example, the Oncology Nursing Society, we have a meeting next Monday to discuss on how we can partner, especially in training. We also have meetings sometime end of September with ISONG leadership to bring in more nurse trainees into Symptom Science Center and exposed to all these different opportunities. So, as I've mentioned, NINR and the core and the heart of the Symptom Science Center is really committed to training, particularly to develop the next generation of nurse scientists. So the most common, and that has been mentioned a lot this afternoon, the most common and established training of the NINR Division of Intramural Research are the SGI, which is coming to its 20th year, which is really very exciting. Of course, the mostly popular methodologist boot camp, which oftentimes close within seconds after registration opens. So please take note of when the next registration is opening. And of course, we have a lot of really talented students that are coming through our graduate partnership program at the moment. As mentioned, we also have different opportunities of fellowship, for example, post-baccalaureate fellowship and the postdoctoral fellowship. And as Dr. Gill mentioned, we are happy to welcome, which started actually 2 weeks ago, Dr. Letitia Grave, our first postdoctoral fellow that started through the Symptom Science Center. This is our partnership, NIR's partnership with the Robert Wood Johnson Foundation for early career investigator who will be mentored, not only exposed to different core labs in NINR as well as other NIR partners, but also be mentored in grant writing as well as different on-campus trainings. So in this particular opportunity and time, we have really reimagined how we move forward with our training. We've looked at our curriculum and how we can utilize Symptom Science Center as a core of the training opportunities for all neuroscientists that will be going through NINR. So we plan to rotate potential trainees through different NINR groups and exposing them to the 3 pillars of the Symptom Science Center, hoping to improve the rigor of their investigations. So what can one expect to gain after training in the Symptom Science Center? Of course, training will be tailored. This will be driven specifically by the trainee, especially the postdoctoral trainee. So it will be tailored depending on the trainee as well, trainee's interest, as well as the length of rotation, especially now that we're having this discussion with different foundations such as the ONS and ISONG. Some of them can commit to short periods of time for their training. So our curriculum will be built based on those demands. There's also opportunities not only in training, but also to reach and build their own matrix of mentors as they rotate in the different labs in NNR, but also potential collaborators. This is an opportunity for our trainees to develop that. And of course, highlight the translational nature of symptom investigation. So those are the different opportunities that we have in the NIR Symptom Science Center, and we're really looking forward to each one of you to be exposed, but also to collaborate with the future activities of the Symptom Science Center. Thank you very much.
Thank you, Leo. We will actually have a panel presentation after the next 3 presenters, but Leo, I see, is not on the panel. Do you have any specific questions about the Symptom Science Center that you would like to ask at this point? And you can bring them up later if you want to. Oh, I'm sorry, Shirley.
I'm assuming that for some of your clinical tools or research tools for measuring symptoms, that you've used some of the promise measures.
Yes, correct.
So what are the plans? What is the sunsetting? Will that affect our ability to access those tools, the cost of them, the scoring of them, that sort of thing?
Thank you, Dr. Moore. Yes, so it will not affect as part of most of the Common Data Elements Initiative, and Jerry can correct me on this. They're utilized. We've utilized the promise measures for the NIR CDEs, and those are available readily through the CDRNS, and a lot of our center P20 and P30 centers are able to use that. Collaboration-wise in the intramural, particularly, those common data elements that we've expanded, used in expanding the CDL library can readily be used, including promise measures, NeuroQual, and we can use that through specific collaborations.
My question is with the sunsetting of the promise. I mean, I'm just wondering, will we now be charged? We go free to a website, we access the tools, we do the scoring and everything. But I'm assuming there's somebody behind that funding all that, okay? And that will now end. And so I was wondering, I thought maybe you would have an inside track into what it will mean for us.
I can only speak from the intramural. we have collaborations, for example, at the moment, that through MTAs or different forms of MOUs, that our collaborators can utilize the CDE library through the intramural space for free, without charge. I know that there are areas that you need to utilize the commercial promise, but through collaboration with the intramural investigators, those are available for free.
And Shirley, we'll have to get the rest, other answers to that.
Because as we
My
move to
assumption is there is-
CDEs,
right.
we want not just intramural, but
Right.
extramural also to be
And that's
using
the
them.
intent. I have not been told anything otherwise, but I think we need to ask the question and just make sure.
So I'll just say one thing. So the promise measures will remain, as far as I'm aware, will remain free and publicly available. Just one note is that this was a common fund funded program that's funded from the Office of the Director, and this is typical for all of common fund programs. They do sunset after a set amount of time, and so this is just part of our normal thing. So I just wanted to point that out, that it's not like there was any decision made to sunset these. That sort of the plan is normally if the ICs that are involved in the common fund programs are interested in maintaining or continuing or expanding the programs, that the ICs come together and do that independently. So common funds are often used to seed things, essentially.
Rita, did you have a question?
Well, I do, but I'm not sure I can articulate it clearly. So it has to do with the biologic mechanism, part of the symptom science framework. So what work is there? I'm not sure it's clear to me what all of the biologic mechanism activity is. Is it all genetic? Is it other kinds of metabolomics? Is it
From the framework itself. So when the framework was created 3 or 4 years ago, or maybe longer now, it was biomarkers were kind of the thing in vogue. And so when I was, along with the rest of the intramural group, created it, and we used that wording. I think I have regretted using that wording, because to us, it's more biologic mechanisms. So it's sort of whatever, if it's the microbiome, if it's the RNA expression data, whatever is that piece that helps move the science, a more biologic piece for the science. That's my personal response to you on that.
Well, so sort of in line, I think, with what Shirley's brought up, is that there's an extramural community that looks at that model and maybe is using it. So I guess then my follow-up question would be, are you all working on updating or revising that model? There may also be behavioral mechanisms that are not at all biologic, and I wondered what sort of exploration that the new Symptom Science Center might be engaged in that would be doing that sort of work as well. And I think that the extramural community would be interested in a revised model, should that be.
And from an editor of a journal, it's always nice to have those types of questions posed.
Well,
The model was proposed, a new model has been proposed, building on that, in the center's paper that was recently put out on precision health. I believe it was that one, where we took that model and made, I think, pretty, I don't want to say massive changes to it, but added a lot to it. It didn't change the original, it just added a lot to it, and created definitions that are more inclusive of more than just genetic markers and that sort of thing.
So in the understanding that we are on a time frame now, and I really actually love the discussion, but I think it's also a challenge that, Leo, you and your team need to look at that model and over time or wherever, but somewhere kind of think about what you want to do with the model and make of the model and the iterations as they go forward.
Absolutely,
So
that'll be
that's
our
great, yeah.
number one item for Monday's meeting.
I'm here 2 weeks, so he's listening to me for the next 2 weeks, and be done. Okay, let me introduce our next speaker then. Our next speaker is Dr. David Brody, and his presentation is going to be an example of some of the collaborations that we have with outside groups. We're very pleased he has come. He's the director of the Center for Neuroscience and Regenerative Medicine and a professor of neurology at the Uniformed Services University of the Health Sciences in Bethesda, Maryland. So he's right across the street from here. So his research focuses on accelerating better outcomes for U.S. military traumatic brain injury patients, TBI patients. He has developed and authenticated advanced imaging technologies to detect injury in the brain's white matter and showed for the first time how to predict neurological function by measuring amyloid, an abnormal protein in the brain. He's also helped discover that diffusion tensor imaging and advanced magnetic resonance imaging technique can reveal blast-related damage. He has previously led a team that worked in partnership with the U.S. Department of Defense in Germany and in 2 sites in Afghanistan, treating U.S. military personnel with TBI. His achievements have been recognized with several awards, including a Career Development Award from the National Institute of Neurological Disorders and Stroke, NINDS, and the Burroughs Wellcome Career Award in the biomedical sciences. So we have certainly enjoyed working with Dr. Brody, and we look forward to hearing your presentation. Thank you.
Well, thanks everybody. Good afternoon. What? Good afternoon. All right. Good. There you go. All right. Good. Terrific. Can you all hear me? Is that better if I use the microphones? Are there people online? Okay. Yeah. Terrific. So first of all symptoms exist in the brain. There's nowhere else that they are. That's where symptoms are. They are in the brain. They may have other mechanisms, but eventually their final common pathway is in the brain. So I think it's appropriate to talk about symptom science, focusing for a moment on the brain. So my work is entirely focused on traumatic brain injury, but I think what the lessons that I'm going to hopefully talk about a little bit today, I think are broadly applicable to a wide variety of other conditions, brain and other conditions throughout the body. And, I've had a great opportunity to collaborate with Dr. Gill, with Jessica Gill over many years now, and we really see eye to eye. So I'm really honored that you invited me to come and speak here today, because I think our views of the world are fundamentally concordant. So the title of my talk today is One Bite at a Time, Clinical Trials for Individual Symptoms of Traumatic Brain Injury. These are my mandatory disclosures. I don't have any conflicts of interest, and these are just my views, not those of the Department of Defense or any of the other organizations. So first, in our center, in the Center for Neuroscience and Regenerative Medicine, we've issued a call for action for traumatic brain injury research, and that is that we are not doing a great job. We've done a lot of work, a lot of science. We've discovered a lot of things about traumatic brain injury, but they have not really led to improved outcomes for patients with traumatic brain injury. So we've called for a call for outcomes, a call for action. Let's do something that really makes a difference. And in order to do that, I'm going to review and identify some of the pitfalls of the things that have not worked and present an overall framework for what we would like to do in the future with regard to traumatic brain injury research. Along the way, I'm going to present an exemplar. I mean, it's one of many exemplars that one could present, but I'm going to present one particular example of a symptom-focused trial that also uses pretty advanced technology to treat the symptom of depressed mood following traumatic brain injury, but using, again, as I mentioned, pretty advanced individual personalized medicine approaches. So the bottom line, traumatic brain injury is a really hard problem. You all work on really hard problems. This is why we're here. We work on hard problems. So the advice from General Adams was, when eating an elephant, take one bite at a time. And so that's what we propose to do. So here's our call for action. There's been over 30 late-phase clinical trials that have failed to translate into a therapeutic in traumatic brain injury. Other fields have similar lesions of failure. There's been limitations of the animal models that have been used to model human traumatic brain injury. They don't recapitulate very accurately the human clinical condition. The preclinical studies have not been very well designed. There's been a lot of heterogeneity in human traumatic brain injury, such that if you have a sort of a one-size-fits-all, you think it's going to work on all traumatic brain injury, it really just may miss the mark because there's so much heterogeneity in the field. Sample sizes have been relatively small. Trial design, patient selection, outcome issues, all have been serious problems in the field of TBI. For this audience, I'm not going to get into it too much because that's kind of more the minutia of my particular field of traumatic brain injury. But I think many of you will probably recognize similar challenges in your own fields. In the end, we have very few solutions for patients with traumatic brain injury. I'm also a clinician. I take care of patients with traumatic brain injury. I started the TBI clinic at Washington University in St. Louis when there were very few such clinics. Now there are lots of them. And I also work at the traumatic brain injury clinic across the street at the Walter Reed Hospital, where we see a lot of service members. But the list of evidence-based treatments for traumatic brain injury is woefully short. So most of what we do is based on clinical experience, which has been defined as making the same mistake over and over again as you get older, which has certainly been my experience. So here, what are some potential solutions? Well, we could do additional large trials in moderate to severe TBI, just like we've done in the past. And this has not really been successful in the past, despite substantial effort. So I guess that's the definition of optimism, is trying to do the same thing over and over again, and hope to get a different result. But okay, that's one possibility. We could focus on prevention, and that's terrific. We have made really terrific strides on prevention with airbags and helmet safety and reduced contact in professional sports and balance training and better for elderly individuals and better military service members. And I'm all in favor of prevention. In no way do I want to take away from prevention, but that's not enough because that would leave our patients that have traumatic brain injuries in the lurch. So prevention's good, but insufficient. And then, of course, there's the option of nihilism, as been advocated by one of our previous NINDS directors, which she said, "See that? That's a squash bug. That's traumatic brain injury. You're going to fix that?" So no, that's not really for us. Yeah, exactly. That's the opposite of optimism. For us, that's not an option. Our patients deserve better than that. So they're not squash bugs. They're wonderful people, and they deserve the best care that we can provide for them. We can double down on basic science research, and I'm not in any way dismissing that. I think it's very important to double down on basic science research and find the magic bullet in the laboratory that really will intervene in the specific pathophysiological processes that underlie the important sequelae, the important traumatic brain injury, and other symptoms. And that's really important. But again, that's a long view because the path from discovering a specific mechanism or molecular target through a clinical therapeutic is in the many decades. So even when things go well, that's a long path. So like a great example in the field of neurology is we have calcitonin gene-related peptide monoclonal antibodies to treat migraine headache. And that's an example of a magic bullet. It's a very specific peptide molecular pathway that underlies the pathophysiology of a symptom, headache, a specific type of headache, migraine, and they really work. But that was about 25 years from discovery to FDA approval. And things went really, really well. And that was with the drug companies pouring gazillions of dollars into getting it done. So that's like your best case scenario is you're going to go from that to symptom management in 25 years. And then finally, we come to the path that I personally favor, which is clinical trials focused on one symptom or issue or subdomain at a time. And that's the one bite at a time approach. And that's what I'm going to spend the rest of the time talking about in terms of bringing things that are useful to our patients sooner rather than later. Does that make sense so far in terms of framework? Pause for questions. Any questions so far?
Actually, because of time, I'm going to ask you just to move on, and we will get to the questions at the end. Thanks.
Say no more. Okay, so the path forward is to identify subdomain specifics and candidates treatments, and each one the focus of a clinical trial. So we have a few success stories: phenytoin and levetiracetam for early seizures, amantadine for recovery of consciousness after very severe TBI, methylphenidate for post-traumatic attention deficit disorder, and also fatigue, by the way. Repetitive transcranial magnetic stimulation for headache and depression following concussive traumatic brain injury, melatonin for insomnia. These are all examples of specific symptoms or subdomains. It's not for globally for traumatic brain injury. These are examples of one bite where we've taken small bites out of the elephant of traumatic brain injury. But in order to do this it's been very irregular. In order to do this in a more regular and consistent fashion, we need some infrastructure. We need a network of clinical trial sites, ideally a single IRB. Key design features: we can move much faster with clinical trial design when we use Bayesian adaptive designs. And I'm going to tell you a little bit about one of the Bayesian adaptive designs that we're engaged in right now. Identifying specific subsets of patients that are most likely to benefit from specific treatments. So, it's nice to take a bite, but it's especially good if you can take a bite of something you can actually chew on and swallow, as opposed to taking a bite of something that's just too big or too tough to chew and swallow. It just doesn't work. So picking the right bites to take is a key thing. And what I mean by that is picking the subsets of patients that you can actually make a difference in now with the specific treatments that you have in your pocket, or could reasonably develop. And domain-specific primary and secondary outcome measures. And so this is where I think you guys especially can be of great help to us, I hope, and that is to find the right outcome measures, because clinical trial is only as good as its primary outcome measure. If you got the wrong primary outcome measure, forget it. You're out of luck before you even start. So because we're focusing on single symptoms, patient-related, patient-reported symptoms, it's critically important to have the right outcome measures, and that's an open discussion. We don't have any standards in our field about what the right outcome measures are, and so this is an opportunity, right, for us to all collaborate and work on this, figure this out together. And so overall, our view is that this approach will transform. It'll reduce the times, cost, and logistical barriers associated with individual trials, such that our goal is to do 30 trials over the next 10 years for about the same cost as 10 standalone trials using this integrated approach. So that's our plan. You'll see me here for the next decade or so hammering away at this. Okay, so what do we mean by one bite at a time? I'm going to just break it down for you. Now we're going to get into the weeds a little bit, and I'm going to break it down for you guys in terms of what do we actually mean by one bite at a time. So the big three in traumatic brain injury are sleep and fatigue, which are really closely linked. Most complaints of fatigue are related to sleep, and most sleep disorders, the main complaint is actually fatigue, and that's a big one. Mood disorders. Depression and anxiety and post-traumatic stress are all really mixed into, most people have combinations of those three disorders. So mood disorders are a major problem following traumatic brain injury. Post-traumatic headache, I talked a little bit about migraine and the pathophysiology of migraine, but that's a really big one. That's actually the most common persistent symptom after traumatic brain injury is post-traumatic headache. And then cognitive disorders, cognitive dysfunction after traumatic brain injury. So these are I guess I said the big three. I mean the big four symptom domains within traumatic brain injury. And these have been pretty well validated across a wide variety of populations, including military service members of these four clusters. And then in terms of what can we do? How can we take bites out of these? We've got a few domains. We've got therapies, we've got neuromodulation, we've got pharmacological interventions, we've got lifestyle modifications, and we've got some combinations, some hybrid approaches. So, for example, in the domain of mood disorders, cognitive behavioral therapy is terrific. It definitely works for mood disorders in the setting of traumatic brain injury, but we can't bring it to a nearly large enough population. We have enough cognitive behavioral therapists, well-trained therapists, to deliver the therapy to about 5% of the people who need it. So that's woefully inadequate. We are not going to hire 20 times the number of therapists. I mean, I wish we could, but I just don't think that's going to happen. So one of the things that our group is doing is we're developing smartphone apps that will deliver the basic principles of cognitive behavioral therapy specifically tailored to military service members with traumatic brain injury. And many of these young men and women would actually rather interact with their smartphone than they would with an actual therapist. So if any of you know a lot of 18 to 24-year-olds, you won't be terribly surprised by that, but that is in fact the case. So smartphone apps to deliver cognitive behavioral therapy is a big area and very specific focused cognitive behavioral therapy in one domain, not broadly whatever you need, but just really focused in on depression or really focused in on one symptom cluster. So that's an example of a trial that we're doing. We're developing the app, and then we're going to do a randomized controlled trial in that domain. In the domain of mood disorders still, transcranial magnetic stimulation is a big treatment for depression and has the opportunity to be personalized, right, in the sense that you can use resting state functional connectivity, MRI, a very high-tech brain mapping approach, to map the specific mood regulation circuitry in the individual person and deliver the transcranial magnetic stimulation right to the spot that is appropriate for that individual person. And so I'm going to show you some examples of that in the next few slides, because that's an area that is ongoing. In pharmacology, most of the pharmacology we do is focused on existing medications applied to new therapeutics. So lamotrigine, for example, is a drug that we use a lot for mood stability. We don't have randomized controlled data about whether it works for mood stability. It works in bipolar disorder, has similar symptoms. We'll see if it works in traumatic brain injury patients with mood instability. We'll find out. We don't know. Intense daily cardiovascular exercise, also something that anecdotally works very well for the symptom of mood instability in traumatic brain injury patients. But again, we don't have randomized controlled trial data. And so you see what I'm giving you the idea of some of the one bites at a time. And you can read some of the other ones. So some of the other ones are in here, including things like vagal nerve stimulation for post-traumatic headache, and this calcitonin gene-related peptide for acute post-traumatic headache, and long-acting stimulants for cognitive endurance, et cetera, et cetera. Vagal nerve stimulation paired with cognitive rehabilitation as one of the hybrid combination examples. Down here in the see if that actually works. Okay, go back. As one of the examples, that's this one right here. Yeah, vagal nerve stimulation paired with cognitive rehabilitation as an example of a hybrid or combination measure. So hopefully that makes sense as well. What we mean. These are just some examples to tell you what we mean by one bite at a time. And this is not meant to be an all-inclusive list or even a particularly well-validated list. It's just really some exemplars. And this is, we wrote a review or an opinion paper in Annals of Neurology, which was just published earlier this year, exemplifying what we meant by this approach. Okay, so now just for fun, I'm going to dive into a specific example. So this is the domain of mood disorders, and it's a depression, population of concussive and moderate brain injury with depressive symptoms. Ultimately, depressive symptoms are, in our hands, in our population, the largest determinant of quality of life. Very strong correlate, the strongest correlate of quality of life measures, global quality of life measures, is the severity of depressive symptoms. No surprise, right? That's true in many, many diseases. So this was one of the first things that we went after. Plus the fact that military service members are committing suicide at a rate of 2 a week in the United States, which is shocking and awful. It used to be that military service members had a much lower suicide rate than the general population, but now it is equal to or slightly greater than the rate in the general population. A lot of it is driven by depression, not all of it. I certainly would not say suicide equals depression, but depression is a big chunk of suicide. So our primary outcome is this Montgomery-Ashburg Depressive Rating Scale, which is a pretty well-validated symptom cluster report. And this is a case where we do actually have a pretty good idea what the right primary outcome is, because this Montgomery-Ashburg Depression Rating Scale has been used in a wide variety of pharmacological and non-pharmacological treatment trials in the domain of depression. So it is pretty well established. But in some of the other domains, we don't have a really well-established primary outcome. This is where we're standing on pretty solid ground. This is what TMS looks like. Many of you have seen this, not everybody. TMS involves a figure-8 coil right there that produces a very strong magnetic field that moves very fast. It's a fast pulse of magnetic field, and it induces electrical currents in the brain. So it's non-invasive. It sits on the top of the head, as you can see from from the picture right here. It sits on the top of the person's head. It's stereotactically navigated, so that's in a very precise coordinate, focusing on a very specific area in the person's head. It's about 2 centimeter region, as the focal area of stimulation, and it induces a pretty strong electric current in the superficial areas of the brain, strong enough that if you stimulate over left motor cortex, you'll get a twitch in the right thumb. So it's really a direct stimulation. There are other methods of stimulating the brain that are much weaker that would be called modulatory rather than directly stimulating. But this is a direct stimulation effect. And in fact, we figure out how hard to stimulate based on how much you need to get a twitch in the contralateral thumb. That's how we figure out the dose. So that's what this looks like.
David, I apologize for interrupting. This is very interesting. We have about 5 4 to 5 more minutes for you.
Good. Oh, I have about 4 or 5 more slides.
Thank you.
So terrific. All right. So here's how we do it. We take a resting state fMRI of each individual subject, and we map their brains. And we get an individual map. These are examples of individual subjects, and they're different. Each person is different. The mood regulation circuitry in every person is different, and every traumatic brain injury is different. And so the target location is different in each individual subject. And so here's an example of, we found the hot spot in this one particular person. This is a retired National Football League player who'd had several hundred concussions in his life and was living in his mother's basement, divorced, unemployed, couldn't exercise, just absolutely miserable, totally apathetic. And we found the hot spot in him that was quite different from what you would get if you had a regular TMS. This guy, by the way, had failed cognitive behavioral therapy, multiple antidepressant medications. Nothing had worked for him. So we found a specific hot spot in him. He was part of a randomized controlled trial that has a flow that looked like this. It was a very small pilot trial. And we gave 20 sessions, 20 one-hour daily sessions. And this is the result. This is the symptom is on the left axis, the MADRS. And you can see what happened in the active patients. Many of them got better, not all of them. And in the placebo patients, the control patients, they also got better, but substantially less. This has a great placebo effect. You get some caring physicians who have this really high-tech apparatus. You get a fancy scan. You get somebody paying attention to you for 20 days. And the placebo patients got better too, but not as much as the actual patients. And so this is what happened to the various individual subsymptoms. Interestingly, the thing that got better the most was apathy. So apathy, again, related to fatigue, was the specific subscale in this that had the biggest benefit. So we were pretty excited about that. And it was, for example, in this individual that we were talking about, he was able to start getting back to the gym, which he'd never been able to do before because he was so apathetic. And he was able to start going to therapy, which he couldn't do before because he was just so fatigued, low energy, no motivation, nothing. So that was good. This is a very successful thing. So we're in the process. There's a lot of unknown questions about transcranial magnetic stimulation, including whether this personalized medicine approach makes any difference, whether you have to do both sides, whether you can do it faster. An hour times 20 minutes is a lot of effort. Whether we can do it faster would be great. So we're doing what's called a Bayesian adaptive design trial, where we have 12 different varieties of transcranial magnetic stimulation, and we're going to test them out in a multi-center trial. And depending on how things go in the first 10 patients per arm, we will then increase the randomization probabilities in the things that are working well and decrease the randomization probabilities in the things that are not working so well and loop it again. And we will quickly converge on which subset of transcranial magnetic stimulation is the most effective using this Bayesian adaptive approach. And so this is an efficient way to sort through a variety of potential treatments when you have a fast feedback mechanism, when you have something where you have some information that you can use to adapt. So anyway, that's what we're doing. We're doing numerous late phase stages that are all late phase clinical trials that are all focused on specific symptoms related to traumatic brain injury, and using this one bite at a time approach and incorporating the principles of Bayesian adaptive design to make it more efficient. We hope that this will dramatically reduce the time and effort required to bring improvements in quality of life and symptoms to our patients, irrespective of whether we ever really discover like the magic bullet or not. We still think we can take some solid bites out of the elephant of traumatic brain injury. And so this is our research group, and thank you for your attention.
Thank you very much. And if you could stick around for our panel discussion in it'd be about 30 minutes. Is that okay?
Oh, absolutely.
Great. Okay, our next speaker today is Dr. Rebecca Fine. She's a research fellow in the Symptoms Biology Unit in the Symptom Science Center, and she received her doctorate from Georgetown University Medical Center with a focus on the role alpha-synuclein plays in Parkinson's disease. She went on to do her postdoc research at Max Planck Institute in Munich, Germany, where she was part of a team that discovered a possible common mechanism of multiple neurodegenerative diseases, including Alzheimer's disease, Parkinson's disease, and others. Since joining NINR in 2015, Dr. Fang has devoted her efforts to uncovering mechanisms of the pathogenic process of cancer-related fatigue. She is also an active researcher within the chronic fatigue syndrome that's going on, a study that's going on here at NIH. And that's a condition that is poorly understood and currently has no cure. Thank you very much for presenting.
Great, thank you. That was a tough act to follow, Dr. Brody. So I hope you guys are still doing well. So I know most of you, I'm a research fellow within the intramural division of NNR, and I hope to tell you about some of the work that we've been doing within the Symptoms Biology Unit and the Symptoms Science Center led by Dr. Saligan. Okay, so before we dive in and talk about the mechanisms of fatigue, we have to first define fatigue, right? So what is fatigue? Fatigue is a subjective experience that's characterized by a lack of energy, both in the physical and cognitive domains. So what differentiates pathological fatigue from the normal tiredness that you and I feel is that, one, it's not proportional to recent activity, and two, it's not relieved by sleep. It's actually fairly common. It's been observed in sleep-wake disorders, multiple sclerosis, stroke, cancer, and also the CFS syndrome that we will be talking about a little bit. So our group focuses on cancer-related fatigue, and it's a very common debilitating symptom that's reported by up to 80% of all cancer patients. The current issue with cancer-related fatigue is that it tends to be underdiagnosed and undertreated. So right now, cancer-related fatigue is almost entirely diagnosed using self-report questionnaires. So here's an example of a questionnaire that our group and a lot of oncology groups like to use. It's the FACTF, and PROMIS is another popular one within oncology groups. So as you can imagine, due to the subjective nature of self-report questionnaires, the specific questionnaire you use and also the cutoff scores you use to define fatigue matters a great deal when it comes to studies of fatigue. So in a paper we published in 2016, oh, here's a pointer. It will require motor adaptation. So using the three commonly used fatigue definitions, not only do we observe different longitudinal fatigue symptom trajectories, as you can see, I'm learning, my motor cortex is slowly adapting. It's not that easy to use, you guys. Okay, cool. Maybe so the mouse pointer doesn't work. Anyways, maybe I'll just point. So not only do we see different, then the mic doesn't work. We also see different gene expression patterns associated with fatigue. So obviously, right, using self-report questionnaires has its limitations. And if you want to study whether fatigue is central or peripheral, brain or muscular, you have to use objective measures. So in a paper we just published actually 2 months ago, or a month ago, we found that the static fatigue index calculated showing, in figure B, we found that the static fatigue index calculated using the hand grip device correlated significantly with self-reported fatigue symptoms. But interestingly, though, it's not that these patients are any weaker than non-fatigued patients because we didn't see any difference in maximal strengths, but it's total work performed over time that differentiates fatigued patients from non-fatigued patients. And similarly, in the cognitive domain, we didn't see any difference in their peak performance accuracy using the commonly used Stroop test. But we did see a difference in the cognitive interference score, which is calculated as the difference in reaction time between the incongruent and congruent plus neutral conditions. So this suggests that fatigue, both in the central and peripheral domains, is really related not to peak performance, but rather performance as a function of time. And another thing that's worth pointing out is that because of the increased cognitive interference, we thought that maybe it's due to an impairment in the executive function domain, and that's actually consistent with our earlier publication last year, actually, showing that there was an impairment in executive functioning. So what causes fatigue, right? That's the million-dollar question. So we think that it may be due to inflammation in mitochondria. So, when you're sick with a flu or cold, I'm actually recovering from cold, hence the water bottle. You feel tired and lethargic, right? So what this tells us is that there's an immune component to fatigue pathogenesis. In fact, you can inject LPS systemically into an animal to mimic bacterial infection and induce fatigue. You can also put IL-1 beta or TNF alpha directly into the lateral ventricles of a mouse or a rat and induce fatigue in a time and dose dependent manner. In a study that was just published this year that received a lot of media attention, that even made it into the popular NNR daily news briefs, I don't know if you guys saw that, Russell and colleagues showed that interferon alpha treatment in humans for hepatitis C caused immediate and, importantly, persistent fatigue. So that's actually consistent with our own finding. In a paper we published in 2017, we showed that serum levels of trail was upregulated in fatigue patients compared to non-fatigue patients. And the serum trail levels also correlated with self-reported fatigue symptoms. And we're actually, this is really exciting, we just got the data last week. We're collaborating with Harvard, looking at a total of 570 patients. And guess what? Trail repeated. So that's really very exciting. And in a different experiment using whole genome transcriptome array analysis, we saw an upregulation of the trail decoy receptor. So this is interesting. So trail stands for TNF family apoptosis-inducing ligand. And in humans, it has 4 different receptors. Let's try this pointer again. So trail binds to the extracellular binding domain, right, and causes apoptosis when it binds to the first 2 receptors, R1 and R2. And there are 2 other receptors that only have the extracellular binding domain and lack the intracellular death-causing domain. So when trail binds to these receptors, nothing happens, hence the name decoy receptors. And it's usually upregulated as a compensatory mechanism so that, when your body secretes or expresses a trail, most of your cells don't die. So trail just kills whatever it needs to kill. Neurons, interestingly, only express the trail receptors with the intracellular binding domain. So that means even at a low dose, over a long period of time, when neurons are exposed to trail, you can get neurotoxicity. And that's exactly what we saw as well. When we treated neurons with extracellular trail, we see this dose-dependent cell death. So, but then the question is, these patients, so you probably heard from Leo's talk, these are prostate cancer patients that receive external beam radiation therapy, right? So why is it that when they have the same kind of cancer and they receive the same kind of treatment, why do some people develop persistent fatigue and some don't? And we think the answer lies in intrinsic genetic vulnerability. So in a paper we published last year in Nature Translational Psychiatry, we found that metabotropic glutamate receptor 5, or mGluR5, at baseline can predict the fatigue outcome 1 year after radiation therapy. So you guys are neuroscientists. mGluR5 plays an important role in neurotransmission, right? What's less known about mGluR5 is that it also plays an important role in immune synapses. We can talk more about immune synapses later if you guys are interested. So these are structurally and functionally similar to neuronal synapses. So we found that mGluR5 activity itself doesn't affect T-cell behavior. Interestingly, if you activate mGluR5 by treating T cells with an mGluR5 agonist 20 minutes before you irradiate the cells, you see that mGluR5 activity enhanced the effect of radiation, both in terms of apoptosis and receptor clustering and also Rantis release. Whereas if you block the receptor before you irradiate the cells, you can reverse the effect. So what this tells us is that perhaps intrinsic genetic vulnerabilities can modulate the threshold beyond which inflammation becomes chronic inflammation. and fatigue symptoms appear. So, oh, there we go. Okay, but then the next question is, how exactly does inflammation cause fatigue? So the flip side of fatigue is the lack of energy, right? So perhaps, if you have mitochondrial dysfunction, that may explain fatigue behaviors both in the cognitive domain and the physical domain, because after all, every cell needs mitochondria. So interestingly, mitochondria are particularly vulnerable to circulating cytokines. So inflammation can induce mitochondrial dysfunction. Mitochondrial dysfunction can cause damp signals such as mitoDNA and other damp signals that can be released from dysfunctional mitochondria can then lead to inflammation because, damp TLR signal and then NF-kappa B transcriptional activity. So then that led us to look at mitochondria and its role in fatigue. We all know that mitochondria are the main supplier of ATP within a cell. Mitochondria also play an important role in calcium regulation, apoptosis, and redox signaling. A cool fact about neuronal mitochondria that I think not everyone knows is that mitochondria are always on the go. They're always being shuttled, sometimes up to several feet to reach their destination. So as you can imagine, because of the important role mitochondria plays in cellular function, mitochondrial dysfunction has been implicated in a variety of psychiatric disorders. In terms of mitochondrial dysfunction and fatigue, the field is fairly new. But in 2016, Lawson and colleagues showed that...
Rebecca, 3 minutes.
3 minutes? Oh.
Or less.
Or less. This will be interesting. Okay, so background literature suggesting that there's some evidence suggesting that mitochondrial dysfunction may play a role in fatigue. And then we can talk more about this if you guys want. We've, in fact, published a very detailed protocol paper. So this is what we use to study mitochondrial dysfunction. And in a functional test, we measure all these variables that I would have loved to tell you about. So this I do want to talk about. You may be thinking, these are PBMC mitochondrial function that we're measuring, right? So how much does PBMC mitochondrial function tell us about the rest of the body, like neuronal mitochondria and muscle mitochondria? So in a study published in 2014 by Paul's group here at the NIH, they showed that the protein expression levels of complex 5 correlated significantly with basal oxygen consumption rate measured using the technology that I was going to tell you about. In another study published by Anthony Molina, they showed a significant correlation between monocyte maximal respiration and also skeletal muscle cell respiration. So this suggests that even though PBMCs are not perfect, they are an indirect but valid marker for the overall mitochondrial health in the body. This I'll skip. So we found a decreased coupling efficiency in the fatigue patients, which I think is very cool. And if you'd like to learn more about how to calculate the coupling efficiency, I'd be happy to tell you about during our panel discussion. And also, we are part of the trans-NIH CFS protocol led by NINDS. So we also looked at mitochondrial function before and after exercise. And lo and behold, we found that in the healthy controls, there was an increase in both maximal respiration and spare respiratory capacity after exercise from baseline to 24 hours after exercise. In the fatigue patients, though, they either stayed flat or went down. So this suggests that there may be a difference in the way that mitochondria respond to stressors that's different. This I probably don't have time to go into. So we also looked at brain mitochondria, but to do that, we have to use an animal model. And we can tell you all about the animal model too later if you guys want. But basically, we saw a decrease in the mitochondrial transcription factor, TFAM, and also a decrease in the glucose transporter, GLUT4, in the irradiated and fatigued mice in the brain. So this suggests that peripheral inflammation can affect brain mitochondrial function. do I have time for this? 2 minutes? Okay, so within 90 seconds, I hope to tell you about an ongoing project that we're really excited about, as you can see later on. So if you remember from my earlier slides, mitochondria are always being shuttled, right? Mobile mitochondria help remove excessive calcium from the synaptic terminal that helps prevent excitotoxicity that's prevalent in Alzheimer's disease and traumatic brain injury. Mobile mitochondria also help move synaptic vesicles from the reserve pool to the readily releasable pool. So mitochondria trafficking, as you can imagine, is very important for the overall neurotransmission. So recently, we found a single nucleotide variant in the BDNF gene that's very significantly correlated with the self-reported fatigue symptom severity, a p-value of 0.002, which is pretty amazing clinical studies. So BDNF, turns out, directly affects mitochondrial mobility and synaptic plasticity. So we will be using live cell imaging to track mitochondria in a live cell. So this is a differentiated neuronal model that we developed. Let's see if that'll work. So you can see mitochondria in the cytosol and also dotted along the processes, right? So the 3D movies, just to give you a sense of the 3D structure. And over here on the right, red is SV2A, so that's staying synaptic vesicles. So these red dots that you see are synaptic terminals. As you can see on days in vitro 18, these neurons form extensive networks with multiple synapses synapsing onto the same neuron. So just one more. Okay, all right, so with the state-of-the-art high-speed instant structured illumination microscopy, I think that's only available here at the NIH. We can now track subcellular organelles at an extremely high speed and resolution. So here we have BDNF that's localized diffusely in the cell body, but you can also see BDNF concentrated in the synaptic terminals. And in neurons, we can also use Mitotracker so Mitotracker is a dye that goes into a membrane space that has the potential differential. So it's both a structured dye and also a functional dye. So we can now track mitochondria. I don't know if you can see the 3D morphology of these structures. So it's very cool. So the goal is to transduce these neurons with the BDNF, the wild-type BDNF, and compare that to the variant form that we found that's significantly correlated with fatigue symptoms. All right, just to summarize, we found that fatigue is both central and peripheral, and we think that it's a result of intrinsic genetic vulnerability combined with external stressors that eventually leads to fatigue. And we think that everything then precipitates into mitochondrial dysfunction, and that's what's actually causing the fatigue. And here you can gaze upon the lovely faces of our group. Great. Is that time okay? I'd be happy to answer any question later on during the panel discussion.
As you can tell, she's very enthusiastic and she is not fatigued.
I'm actually fatigued today, cold.
Very, very smart, and we're very fortunate to have her with us in our labs. So thank you, Rebecca. Our next speaker is Dr. Vivian Gudez, and she's a research fellow in the lab of Dr. Jessica Gill, where she examines the biological mechanisms underlying traumatic brain injury and related comorbidities, including post-concussive syndrome, depression, and post-traumatic stress disorders. She's interested in neuroscience and also cognizant of the massive burden associated with neurological disorders and still limited understanding of the brain disorders. She pursued her PhD at the University of Sao Paulo, Brazil, and during her postdoctoral fellowship in the Center of Excellence for Aging and Brain Repair at the University of South Florida. She focused on TBI-induced neurodegenerative processes and their links to neuropsychiatric illnesses, as well as development of a novel therapeutic strategies for TBI. She's perfect for Dr. Gill's lab, and thank you.
Thank you so much. And if Rebecca had a hard mission before, mine is twice as hard because I had the 2 wonderful talks before me. But I'm very happy that I just made it here today. I came drove insanely from Washington downtown today. I was in Constitutional Hall with other 1,000 people from 117 countries. I got my U.S. citizenship today.
Congratulations.
Thank you. Thank you very much. And I'll try, consider the time, we're going to try to tell a shorter version of my presentation. I'll be happy to discuss any details in the panel sections, or always you can reach me through email. If I got the right, no, I do not. How do I do this? No? Oh yeah, there it is. Got it? Yeah, that's fine. Oh, thank you. No, it all makes sense. Thank you. So again, a shorter version. So we work with traumatic brain injury, right? Traumatic brain injury, I feel that Dr. Brody did an amazing job talking a little about, but I just wanted to highlight how heterogeneous traumatic brain injury is. Traumatic brain injury is not one pathology, it's several, right? We can divide according to severity. In the mild, moderate, and severe TBI, we will study all of them, mostly mild TBI, which is most common. But we study, so it is heterogeneous, it's variable, not only according to severity, but also symptoms. So there is a high diversity of symptoms associated with TBI. Many of them might become chronic. And the 2 of them are going to be the topic of our talk today. What I'm going to talk to is part of the interest of, is one of the branches of our lab currently, right? So I'm going to talk a little bit about fatigue. I feel like Rebecca covered the most important aspects of it, and sleep disturbance, and the relationship between both and the link to traumatic brain injury. So fatigue is going to affect from 30 to 80% of patients, sleep disturbance from 30 to 70%. You see the estimates are very variable because they're both very hard to study and very hard to evaluate objectively. Sleep disturbance, though, there is not only subjective but also objective effects or differences when you compare patients with traumatic brain injury and those their controls. And objective, I mean polysomnography, this type of measures. So just to remember that the challenge here, fatigue, it is a challenging subject. And in this case, the traumatic brain injury, we can consider various factors before the lesion, during the lesion, and after chronically that might affect for the symptoms of fatigue that are reported by the patients. Right, so all that makes more complicated to isolate mechanisms and risk factors and the relationships between fatigue and other symptoms. So about the sleep disorders is also not a simple component of the pathology post-TBI. Here is just the results of meta-analysis just to illustrate this. There are many clinical features and symptoms of sleep disorders. They appear frequently after traumatic brain injury. Insomnia here in the top of the table, but the sleep apnea, curiously, it is high. There is a high incidence in TBI patients in control with the normal population. And there you go. So interesting to say, though, and I think this here is the same way that in fatigue, there is a lot of different mechanisms potentially underlying sleep alterations after TBI. They might be because of factors before their injury, during their injury, including lesion of specific structures and circuits, functional alterations because of that, might be because of reflex of psychological, psychiatric alterations and symptoms and the environment that people live after traumatic brain injury. So it is a challenge to isolate all the factors if possible at all. And here, so why is sleep and fatigue important? Yeah, they're important because of physical health, mental health, emotional health. It's harder to think what is sleep and that is not related to. Of course, there is also hormone alterations that happen that I can discuss in details later if you're interested. With sleep deprivation affects our metabolism, can contribute to obesity, and the cleaning of proteins such as tau in the brain also affected in conditions associated with sleep deprivation. So the idea here, I'm going to just hold a little bit. I got 3 slides that I'm interested. Actually, just because the challenge here is illustrate the complications of study the links between fatigue and TBI, right? So I put the very loaded slide here, but that's the case of daytime sleepiness. So daytime sleepiness is common, right? Will affect anything between 14 and 57% of individuals. Is one of the main symptoms of many primary disorders. And one of them is sleep-related breathing disorders, such as sleep apnea, actually also more common in TBI. I said that before. But subjective reports of sleepiness do not always correlate with the quantitative measures, such as polysomnography. And TBI patients underestimate or tend to underestimate their levels of daytime sleepiness in comparison to healthy controls. So in excessive daytime sleepiness can be confused with persistent fatigue. Sleep problems can increase the symptoms of fatigue, and fatigue can be a symptom that appears independently of sleep problems, but they are, as Dr. Brody said, linked. But anyway, so just to illustrate how it's complicated, it can be complicated to separate things in the isolated risk factors. So a lot of the projects in Dr. Gill's lab are with military individuals, veterans and active duty military. So sleep in the military is particularly problematic, right? So shift work is very variable, you have safety concerns, you have overcrowding in sleep areas. So if sleep problems, and we know we have indications that sleep problems can exacerbate TBI-related symptoms, so they'll make the military populations at a special risk of poor outcomes after TBI. So fundamental questions in the Yale lab would be, so do biomarkers, can we use biomarkers to identify those that will and will not recover of the concussion? And those that will recover or mild TBI, or TBI in general, those that will recover better. And can we isolate the risk factors or underlying mechanism specific for different symptoms, right? So about fatigue, right? Fatigue we have been talking recently. So there is biomarkers related to fatigue. And what's the role of sleep in it all? The sleep in it all. So biomarkers can help to improve TBI care in multiple levels, right? And we hopefully biomarkers can use also to improve patient outcome ultimately. All right, so looks complicated, will not be swear. I just want to say that from genetic to environment, a lot of things can be underlined, individual variability, individual response to a pathology, in this case TBI, but also give you a lot of opportunity in different type of biomarkers that you can explore, right? RNA, microRNA, protein, and my favorite, exosomes. Right? We can use any of those as a candidate biomarkers in different projects. So to just give an example of the type of project we're doing, this study was done in so the goal of the study was to do that. So it was a military population, and we wanted to see alterations in the gene expression using RNA sequencing. So here I'm showing 3 different comparisons. That it is PTSD with sleepiness versus control, PTSD versus control, and PTSD with sleepiness versus PTSD without sleepiness. So everybody here had a TBI, right? Everybody in the third case there, everybody has PTSD. Some have PTSD in sleepiness, some I don't. And I'm highlighting it because we have a massive gene regulation. when PTSD is combined with daytime sleepiness. All right, what a type of gene regulation, gene alterations you might ask? Well, there is I'm giving 2 examples here of pathways we generated using IPA, and it is carbon metabolism. Also, there is ubiquitination and mitochondrial activity and inflammation-related pathway that kind of give us a clue of what might be underlying the poor outcomes with people with PTSD and also sleep problems. Another example of study our lab is this one that is basically these people with TBI also, and we compare those with fatigue to those with no fatigue symptoms. In this case, we decided to evaluate proteins, and we evaluate the free proteins in the serum as well as proteins that were inside the exosomes. So we lyse the exosomes and measure the proteins that were inside them. So we're still writing this paper, I'm still analyzing the data, so I'm going to show one graph of this data, which is very surprising for me, because what we observed was for exosomal NFL, we have higher levels in people with no fatigue compared with people with fatigue. NFL is an injury, neuronal injury marker, and usually we observe the opposite, higher symptoms with higher concentrations of them. So we still needed to play with the data, but it's just an example of things we can do in the field of biomarkers and exploring fatigue and sleep problems and sleep disturbances. All right, so let me come back here. So that's my last slide, so I guess I can slow down a little bit. So I gave examples of studies of a lab exploring sleepiness and the symptoms post-TBI. Example of studies more focused on fatigue using gene expression or proteins collected from the blood as biomarkers. What about both then? What about you compare both and you evaluate in the same population? So that's a study we're about to start. Is going to be done in collaboration with the Leo Saligan's team. And the idea is to evaluate TBI patients, right, with fatigue and without fatigue. And they're going to be 2 visits, basically, right? We're going to have a screening visit, or this person is going to answer to self-reported questionnaires about TBI symptoms and fatigue, and including PTSD and depression, right? In the second visit of those people are going to spend 2 nights in a hostel. During this time, they're going to, actually in the first screening visit, they're going to receive Actigraph, and they're going to receive a sleep diary. So you want to collect data regarding activity, like daytime activity of those people, when they sleep, when they wake up, and exposition to light, right, with the Actigraph, and with all those environmental information, with all these subjective reports, right? They're going to come to the hostel, and they're going to spend 2 nights with us. During this night, they're going to we're going to perform a polysonography, and we're going to have a serial collection of blood during the night at different time points. We wanted to collect blood to measure mitochondrial activity, to measure different hormones, including those I talked about in the beginning, related to leptin and ghrelin. We're going to perform neurocognitive tests, and they're going to be, we're also going to perform MRI to investigate structural changes in the brain of those individuals. So with that, using as many scales as you can possibly think, we hope to get enough information to at least start seeing isolated risk factors and the mechanism underlying sleep in the TBI, post-TBI fatigue. And hopefully, this is going to somehow help us to improve patient outcome, reflecting patients' life and generate, improve quality of life for those individuals.
Thank you, Vivian.
Thank you so much.
Do we have room on this end? Okay. Can you help them, Nathan? Do you have, you're fine. So I just want to say we're setting up for the panel. We'll be doing that for about 15 to 20 minutes. And yes, why don't we sit them down there?
We only have one mic, so it won't really work.
Oh, okay. Then if David and Vivian and where did Rebecca go? Right here, right behind you. If you would go down there. We're going to do the panel next. Thank you. So I did want to pull it together with what Vivian said at the very end. She's talking about a clinical trial that we're getting ready to start here in the clinical center. And it's very exciting to see how you're bringing a lot of the biologic data that you have already collected and really getting a lot of the behavioral data from the patients in the clinical setting as well as at home. And seeing how they're actually doing this at home. So while we don't always present on some of the activity and more behavioral data, we are collecting it. We do publish on it. And it is exciting to see, as you were expressing, this maybe make a difference in real outcomes on people. So thank you for bringing that full circle for us. Okay, at this point in time, we have an opportunity to actually follow up on some of the presentations today and the type of science that we're doing in our intramural program. And so can I open this up to questions? Yes, Deborah.
I'm impressed with all of your studies. It's just very, very interesting. But given that the topic looking at sleep and fatigue, I'm wondering if consideration has been given to some of the social determinants of health, like the environment that someone is sleeping in, interruptions that might be occur, and if not now, is that part of the plan for future research?
Yeah, no, it doesn't verify.
Push the button.
Thank you. Begin there. That's a verified carry. Oh, I see. So okay, I see. Just one. I thought it was like, no, at the MRI, we need to keep it pressed. So, so I'm thinking I'm with a patient right now. They're really similar microphone then. All right. But, so it's a very valid point. It's true. And I feel like it's very hard to assess that, right? Some of the scales, they do some, at least a little bit, incorporate the environment of the people, but the actigraph we're using also can collect light information. So at least a little bit, talk about the environment. So let's see the amount of light that people are exposed to, right? And at least a little bit of the environmental information. I agree. I feel like the measurements we have, the evaluation of the other environmental factors, relationship with family and this kind of thing, it is very limited. And I feel like, and I agree, that would be important to know, especially in patients with chronic symptoms. I'm sure the support at home, for example, will affect the symptoms, so yeah. Mm-hmm.
In the domain of cognitive behavioral therapy for traumatic brain injury patients with insomnia, that's the main domain of intervention, is in the environment. And so, like, for example, smartphone apps that provide really high-quality cognitive behavioral therapy for insomnia for military service members that are really tailored to the specific environments that are relevant to military service members are really important. Some of the existing cognitive behavioral therapy approaches are very relevant to upper-middle-class professionals, but are not relevant at all and are sort of cringeworthy when applied to military service members. So tailoring the therapeutic approach to the specific population of interest is critical for efficacy.
I just want to bring up one point. So in terms of sleep, right, it's actually really interesting. So we define fatigue as one entity, but it may not be. So we actually published 2 different papers showing that fatigue during radiation therapy is more related to anemia, and that's symptoms-wise, it clusters with sleep disturbance, right? But 1 year after radiation therapy, it's just inflammation, and anemia and sleep disturbance no longer play a role. So I think, in terms of precision medicine, it may be advantageous to treat fatigue with different mechanism, pathogenic origins differently.
Thank you for those great presentations. I think I want to maybe step back earlier than the traumatic brain injury and ask, is there interest at the Symptom Science Center to look at what is happening with, especially with my population, those of cumulative and historical trauma issues and experiences, so that precision health can be help us to determine what we need to do in order with that. With
Sure, so I can address that. So that's definitely a focus. So anytime we look at traumatic brain injury, we also think about stress. So from a lot of the studies that Dr. Brody's done, as well as me, is having a TBI within combat with that psychosocial stress is very different than having an isolated TBI. In all of our studies, we look at the cumulative impact, starting from childhood. About 25% of the military goes into combat with PTSD or a brain injury already. So we look at the cumulative impact of that trauma. And so we've looked at it in that population as well as in athletes. And now we want to go much more into different populations that are at risk for multiple head injuries. So that will be a big focus of that, and really understanding how much head injury really makes it more pronounced in that individual and that variability that contributes to those long-term symptoms. So that's going to be a big focus of what we do over the next couple of years.
In addition, in the Symptom Science Center alone for our current study, in Picasso study, we recently hired a clinical psychologist, and part of the procedure of the study is to have a really comprehensive a psychotraumatic history taking, and that would really capture that part.
So I have a question about articulation with external and internal research. I guess I think when I'm studying inner city families and with environments that would highly affect possibly sleep and stress and fatigue, and often using actigraphy for sleep and taking good sleep histories and other histories, it seems that if I'm banking blood, that it could be useful to you guys, you know. But I never hear you guys call for our blood. I never hear you, when my grant gets funded, say, geez, could you add this protocol to your new grant, and then we can do. So I just feel like there's a disconnect between us getting a grant and starting a protocol and how some slight alteration in that protocol or communication could aid both of us.
I can address that one too. So what we're trying to do in the intramural program is to create partnerships. Sometimes they're individualized and based on our science, but we want to expand that. So I encourage you to talk with us. We can give you a tour of the lab and talk about ways to do that. But we definitely want to create partnerships. We've got an amazing lab that can look at so many different things. And so we're trying to find ways to do that. So we would love your input on that.
So I would also surely add, and Jessica add, sharing amongst all neuroscientists, right? Yeah. So I'll put a plug out for ONSEN. So, the Omics, Nursing, the Science and Education Network, where you can actually go to that website and fill out the form and say, hey, I have data, I have samples, would love to collaborate, would love to mentor, would like to make these resources available to trainees. I would really advocate that everyone go and take a look at that website and contribute what you can to the cause of sharing and trying to get more bang for our buck out of all of the hard work that we've done to collect data, do deep phenotyping, as well as bank samples along the way. Yeah.
In fact, I'll follow up with, after the council meeting, we will follow information to each of y'all about the ONSEN website and the link to that, so you can go and look at it, because that is something that crosses intramural and extramural and allows for those partnerships that you're talking about, Shirley, for us to know about the potential for those partnerships. And it's funded by NINR. So, yeah.
And so part of that is the reimagining of our training curriculum through our Robert Wood Foundation Scholar. And so part of the goal is to really, for these fellows to come in, to start even learning how to do material transfer agreements, intellectual property, because they're bringing in their samples that they can study here. So that's going to be how we're going to bring in our fellowship.
Any plan for collaborative efforts with NINR funded centers like P30, P20, and also T32 programs?
So those are all things that we want to talk about over the next year. And so what we want to do is really have that formed, have that communication to start. And so we'll kind of reach out to you guys and get some ideas about that, and maybe we can follow up and find a way to connect more.
And I'd like to just add a follow-up point in trying to do that with some sample sharing. If it's not the IRB issue, if you haven't gotten permission up front to do that, it can be difficult retrospectively to go back. So I'd like to add to the conversation, being proactive about consenting, so you're not missing the opportunity.
Related, kind of unrelated to the traumatic brain injury, but I was very interested in the symptom of the sleep-wake, you know, and the thing, because I think that has a lot of implications for the life that we live in. I mean, for children. I wonder if there is, you know, you're looking at some of those related to fatigue and to other things that would have, you know, a major impact in those populations. And you know, just to...
So I can speak a little bit to that, and I think what Vivian was trying to describe, but didn't really have the whole time to. We have a study that we're just starting to look at fatigue, brain injury, and sleep, and so they come to our sleep unit. We have the unique capacity to draw blood while the patient's still sleeping, so we can look at those sleep-wake dysregulations in relation to hormones and all those different biomarkers. So that's one of the ways we're trying to kind of disentangle that. The other thing we've done in our lab is develop a sweat patch, and so that's something that we piloted, so we can actually have a participant wear that in their home environment with an actigraphy watch, and from that sweat patch, they sweat into that, we can extract it, and then we can put it on any of our platforms, look at microRNA, proteins, anything that would be dysregulated related to sleep, and we can do that in the home environment, because we know when we bring them to the hospital, it's going to be very different, especially with children, and so that's one of the collaborative opportunities that we're trying to open up. For other individuals to be able to use this technology. We've actually piloted it out, so that way somebody could wear the patch, just put it in the mail and send it to us, and we can put it on all of our platforms. So that's the way that we're trying to kind of collaborate and connect with all of you guys.
I guess I'm thinking of something more systematic than you call us and we're trying to reach little pockets. I guess, you know, does NINR have a communication path to all the deans of research in the schools of nursing? A newsletter that goes out, you know, copy of the article on the patch for everyone. So to move faster. I mean, I know I'm impatient, but it just seems that a couple hours of good thinking, we could develop a system to move a lot of this faster. I'm just
and so that's what we're looking to do. You know, we've been waiting for our new director. We've got our 2 new people in place. So that might be something that we can start talking about over the next couple months, is really how to do this type of work and to move nursing science forward. We're really excited to collaborate and move it forward. We're looking to you to have us, you know, make those ways come to fruition.
I'm wondering if you're bringing in anything about family systems and relationships and caregivers, family members into any of this work.
Not directly, but but definitely something to keep in mind for future studies. It's just there's so many elements and moving parts, but definitely should keep in part. I feel like it is I feel like there is a intuitive feeling that all then are going to contribute to exacerbation of symptoms post-TBI and to improve recovery, but I'm not aware of objective evaluation of it, though.
One of the key characteristics of the NICO, the National Intrepid Center of Excellence, intensive outpatient program for traumatic brain injury patients just across the street is cognitive behavioral therapy for families and caregivers of injured service members. And there's yoga training and meditation training and education about traumatic brain injury and symptoms, and group and individual counseling sessions on family dynamics in this extremely complex environment. And so the families often come and spend 4 weeks here as well as the service members.
Actually, very good point, and I forgot about that. And we just processed actually samples from NICO now. It's part of the PhD thesis of Heather right here. So we are hoping to write the abstract, the paper soon, so it'll be out there. Blood samples collected from groups at NICO.
Any other questions related to the speakers or panels? If not, I would like to introduce Dr. Larry Tabak. Dr. Tabak is, as we have already said today, he will be the acting director for NINR as of October 1st. And he currently is, his day job right now is as the principal deputy director for NIH. And I am very confident that he is here to answer questions that you have for us today, as well as Tara. So if anybody has any questions that we would like to bring up at this time.
Good afternoon. Good to see you. Rita Pickler.
Yeah.
Do you, are you able to tell us now who is on the new reconstituted search committee?
That information's available. I don't have it with me, but we'll post it publicly. Yes. The committee has now been constituted. They've been charged by Dr. Collins, and so yes, that will be available. I'll start talking about the Krebs cycle. I taught intermediary metabolism for 10 years, so I got really excited when I saw those mitochondria. Maybe I won't, okay? Yeah, thanks, Sam. So let me say just a few things, because it's been certainly an interesting few weeks here for Dr. Schwetz and for me. So first, I want to publicly thank Anne for the extraordinary work she's done, not only on behalf of NINR, but for NIH. And it is not easy to be acting anything. So Anne, thank you again, because we can't thank you enough for all the service that you have provided to us. I guess the second thing I'll say is maybe to explain to you why I care about NINR. I mean, I care about all the institutes and centers at NIH. I have to. It's my job as the principal deputy director of the agency. But, and I'm going to say the D word now, so everybody hold on to your seats. As a dentist, I understand how critically important NINR is to nursing, just as I understand how critically important NIDCR is to dentistry. NINR is the intellectual underpinning of the profession. I get it. And if a dentist doesn't get that, who's going to get it? So that's the second point I'd like to make. Third point I'd like to make is, during an interim period, there is no intent to change the course or direction of the research agenda. Tara is a biophysicist, okay? I'm an enzymologist. I happen to have a dental degree, but if anybody bother to look up my publications, you'll see I'm an enzymologist, okay? And so neither of us are content experts in nursing science. We don't pretend to be. We are surrounded by experts. We're not going to change the course and direction of NINR during this interim period. We will listen very carefully to your wise counsel as members of the council. We will listen very carefully to all the great staff who have been in support of the Institute during this time. So what will we be doing? We're going to build on the great work that Anne began to strengthen further the infrastructure of the Institute so that it can function even better than it is now. Because that is something the two of us really are experts at. Because we do it for the whole NIH. That's what we're going to be doing, is we're going to be looking at ways to enhance and strengthen processes, infrastructure, those things that Anne began, and we will build upon them. It's not really complicated. But the agenda that is laid out in the extant strategic plan stands. Now, if some remarkable new discovery is found tomorrow, and the experts that are surrounding us here come to us and say, you know, we really got to jump on this, and it's not in the strategic plan, but we really got to jump on this, well, of course, then we're going to have that conversation, right? Because we're all scientists. But there is no intent to change any directionality here. Now, you get a new permanent director, that's another conversation. And what the staff will be doing, and they've already begun at some level, what the staff will continue to do is to begin to build their best case for where the direction lies going forward in the future. Because transition, you know, transition's hard, right? No matter what the scene, transition is hard. But to ease the transition of a new permanent director, the best way to do that is for the staff to begin to develop the arguments, the data, the evidence. Here's why we think we need to go in, you know, whatever the direction is that they feel is important. Now, will there be unanimity? Probably not, but that's okay. Because we're scientists, right? And you have lab meetings, and you have conversations. Dare I say you have arguments. It's okay. And that's how you approach this. So I hope you will feel comfortable enough to either ask questions here today, or if you prefer offline. We want to maintain a dialogue. Tara and I are reaching out with Anne's counsel to various stakeholder groups. And I guess there is a series of meetings that we will be able to take advantage of in October, but I'm sure there will be other opportunities as well. We need to have these conversations because the goal here is to even strengthen what is already a wonderful institute, one that is the underpinning intellectually of a profession that's obviously crucially important. So I hope you will take that invitation and will take advantage of it. And so I will stop there and see now if there are any other questions that you may have before you are running for planes, trains, and other forms of transportation. Please.
Dinner.
Dinner. Oh, you have a second day. That's
right.
Dinner. Even more difficult, right?
So, oh no, we'll be fine. So again, appreciate very much your reassurances today as well as last Monday. I don't believe everybody was on the phone with us last Monday when we had the call with council. And I think, again, I said this last Monday, one of the efforts we are trying to make in the same spirit in which you have said we're trying to continue to strengthen the NINR would be some guidance, if you will, on how we help get our next permanent director Who can we look for? What should we look for? How can we help in that process?
Thank you for re-asking the question, because I appreciate that not all of your colleagues could be on the phone when we last spoke. We want a broad search. The most important thing is you want a leader who can sit at the table of institute and center directors and be heard. So acting institute and center director, Dr. Collins sits here, I sit here, Dr. Fauci sits there. Okay, forget about me. That's who they have to sit at the table with, Dr. Collins and Dr. Fauci, and all of the IC director colleagues. That's who you want, because you want the nursing complex, the nursing profession, the research that you all hold so dear to be part of the conversation. So that's the first thing. Now, what are the phenotypes? Cutting edge research. Discipline, you have a very wide breadth of science that you support. In the 20 minutes or so that I was here, we went all the way from mitochondria to, sleep deprivation of members of the service. So any and all of those could very well be cutting edge work, but you want it to be cutting edge. And you know this, omics, big data, behavioral social science research has entered a new era because of big data, because of wearable devices, because of all the other things that we have at our disposal now. So you want a cutting-edge scientist who can really show the very best and most exciting aspects of the fields that the individual will represent. Okay, the person need not look like me in the sense that they do not need to have a lot of gray hair. Okay? I think there was a misperception during the first round that you needed to have many years of administrative experience to do a job of this type. When I was recruited to NIH to be the director of, I'm going to say the word again, the Dental Institute, I was like 47 years old. So you don't need a lot of gray hair, right? What you need is you need a willingness to learn how to run a complex organization in a federal environment. Because this is not like running a department. Indeed, this is not like running a school as a dean. It's a more complex environment, but it is a learned experience. Currently, at the table of institute and center directors, I think this is right, I believe there's only one former dean of a school. Everybody else was department chair or the chief of a division, so there is no need to have run big Now, if somebody with gray hair does show up, that's fine, so I'm not being ageist here, but I do want to emphasize that administrative experience can be a learned art, okay, if you're willing to listen, okay? And I think that, as we work, towards this, the person we want is not looking for a job. I can assure you that. They are not searching the want ads. They are not looking at the Chronicle of Higher Education or the professional journals. They're not, okay? They are absolutely delighted to be in their current position. They love their current job. Everybody loves them. They couldn't imagine leaving their position. That's who we want. And I guess, and for that privilege, I was getting there. Thank you. And for that privilege, there is a reason why we call it government service. So I'll tell you a quick personal story, not that it matters, but what the heck. So when we moved down here in the year 2000, I took a 25% pay cut with 2 kids in private college because it made perfect sense when I was earning 25% more in my former life at the University of Rochester as the, Senior Associate Dean for Research at the Medical Center. Career-wise, fantastic move. Financial-wise, not so much, but, it's okay, you recover. So, but that's the point, is that those candidates who put their name in, they need to understand that, yes, we do have certain salary ranges. It's not nearly as draconian as it used to be, because it used to be really draconian. But fortunately, salaries, particularly for deans, have grown to, I think, nice, reasonable levels. And in general, they seem to be much higher than what we can pay. So, and it is what it is, and that's something I can't control. But the individual can maintain their research program. They would not have a research program within NINR, but rather in a partner institute. So, but they definitely could maintain a research program if they wish to. So there are lots of opportunities, lots of perks, if you will. Salary may not be the biggest perk, but I do think we are much more competitive than we used to be. So, and it's much better to have the conversation than to assume, oh, they can never afford me. Maybe we can't, but at least let's have the conversation. Those are the things that I would keep in mind.
I don't mean to monopolize, but I do have in my head sort of an idea that the director is somebody who, I guess, represents us well, both inside the NIH as well as to the external world. So in some ways, there's a bit of a cheerleader, if you will. Not exactly, but yes, an enthusiastic scientist who willing to listen to the community of scientists within and without about direction and how one molds that, and sort of, really that seems to me that kind of thinking.
And you are absolutely correct, but not too many people in their current roles have the experience to demonstrate that. You see? So what the search committee and what Francis ultimately needs to decide is, does the individual have the potential to do that if, in fact, they haven't yet had that opportunity, right? So, look, people come in different flavors. Some are very gregarious and outgoing, and some are, pretty circumspect. But it's a learned experience. And just because it's not something that you like to do, you can learn to do it, okay? If you want to, if you're willing to. And so media training, coaching, sort of going with a mentor the first, few times to make sure that things go smoothly. Observation by people who've been doing it for many years. All of this is a learned experience. It's a lot of fun, but when you're first starting, it's a little stressful because you maybe never have done it before. So yes, it is absolutely true that ultimately you want that person to represent you before Congress, before different stakeholder groups, before stakeholder groups that you would like to engage with, that you would like to create liaisons with, that you want to spread but not too many folks have that opportunity. Some people in their current positions might, but don't exclude somebody who you think has the potential to do that, even though they may not have done it yet. Now, when you speak to the person and you say, well, do you envision yourself being able to sit before the Congress and testify, and they look at you as if they've just heard some crazy talk, okay, maybe they're not the right person, but most people rise to that challenge. Most people, because they're passionate about what you all do. And when I say you all, I mean literally all of you, because you have such a breadth of science. And that person has to be able to display that passion, that excitement, not only for their own work, not only about mitochondria, which, you were really passionate about your mitochondria. All right. But, tick a box there. But you got to be passionate about the entire breadth of the field. Right? That's very, very important. And I know those people are out there. I'm positive of it. Because I've encountered them at scientific meetings. I've encountered them in the National Academy. I know they're out there.
And I just want to add, after doing this for a year, I found the job to be extremely fun. You are actually sitting at the table, as Larry was saying, with Tony, but with all the other 27, 26 institutes. And a lot of what goes on at that table is some type of, not necessarily at the table, but shortly thereafter, is negotiations and collaborations that are formed between institutes. And I think NINR needs to actually be very strong in that area. We have so much to offer other institutes, but a lot of people don't know what nursing science, a lot of institutes still don't know what nursing science is. So it needs to be a very patient individual to be the director, so they can say over and over and over again with a smile or whatever, not a cranky smile, but a nice smile, that, yes, let me talk to you about this science and how the data we're generating works with the data you're generating, and that we're interested in health outcomes, so that you can do that. So it's a great job. It's very, very fun, and I've had a couple of people come to me and say, should I be interested in it? Yes. Just put your name forward, at least interview, get that experience at this level. It's all about experience and your next steps. And for those that you're talking to, or those on the video cast.
I think the glucose levels are dropping, and there's a need to quickly elevate them. So thank you all for giving me the opportunity to speak with you, and we look forward to working with you going forward.
And we will see y'all tomorrow at 9 a.m. here in this room. Anything else? Oh, you wants me to do the gavel.